Dr. Fahed Saada joins the conference again this year. He's pretty amazing. We're lucky to have him back again. Thank you for coming. And he'll be discussing sleep in Parkinson's disease. But before I have you come up to the podium, I have quite a resume to share with everybody. Doctor, because it's impressive. He's a neurohospitalist at St. Joseph's Hospital Health Center here in Syracuse, where he cares for patients with or at risk for neurological disorders or diseases. He's certified, of course, by the American Board of Psychiatry and Neurology. Dr. Saada earned his Doctor of Medicine from St. Matthew's University School of Medicine, followed by an internship in internal medicine at the Cleveland Clinic, Fairview Hospital, and a residency in neurology at the University of Florida College of Medicine. That's in Jacksonville. Following that, awarded a clinical neuropsychology fellowship at the University of Rochester Medical Center. We finally hooked him and got him up here. And where he was honored with the Neurology Fellow Teaching Award in recognition of his extraordinary contributions to resident teaching. Dr. Saada is now the Section Chief of Neurology and the Stroke Program Director right here at St. Joseph's Hospital. Please put your hands together and welcome Dr. Saada to the stage as he talks about sleep and Parkinson's.
So such kind words. Thank you all for coming today. I came up with a slogan after Dan finished his speech. Yes, we can, Dan. I like that. That's great. I am so honored to be here today, and it's so nice to see everyone, especially after we're all battling with this pandemic and so forth, and the changes that's happening in the world. So it was great just seeing some of my patients here and a lot of familiar faces from a few years ago. I've met Marty at St. Joseph's Hospital several years back, and I've been doing this. This is my third year, and it's been a blessing, really. It's something that I enjoy doing, as well as it's a condition in neurology where we could actually make a difference. We could actually treat. It's not a condition where it can progress rapidly and we can't do anything about. So it's really nice to see patients respond to medications and come back and respond to exercising and have and move forward with their life. It's either being with grandchildren or playing golf. It's definitely an advantage to see that. So with that said, I do work as a local neurologist in Camillus. We have a clinic through St. Joe's. So I've been definitely seeing outpatient neurology patients with Parkinson's. And one topic that always comes up is sleep in Parkinson's disease. And before we move on, no one showed me how to use this, by the way. Here it is. It's very easy. Green. I mean, simple. So before we move on, we're going to talk about the features of Parkinson's disease, discuss the normal pattern of sleep and how it changes and how it evolves over the years as we get older. We'll discuss sleep disorders that are in particularly seen in Parkinson's disease patients. And if we have time, we'll discuss some mental health issues that could be attributed to lack of sleep as well as Parkinson's in general. So Parkinson's disease is a neurodegenerative disorder that affects a part of the brain called the substantia nigra. This area releases dopamine in our system, and dopamine allows us to move during the day, allows us to swallow, controls our gait, controls our mood and behavior. So with Parkinson's, that dopamine receptor or neurotransmitter is unfortunately affected. So really the etiology of Parkinson's in general is unknown, but there's definitely environmental as well as genetic factors. It affects men more than women, and the mean age of patients where they develop Parkinsonian or Parkinson's disease is around 60 years of age. Over the years, we're focused on mostly the motor symptoms of Parkinson's. So for decades, I would say, we are targeting the tremors or targeting the gait. We're targeting all the motor symptoms of Parkinson's, and sometimes we lack or don't focus on the non-motor symptoms, which can be more detrimental than the motor symptoms, as well as can manifest years before the motor symptoms manifest. So for years, non-motor symptoms receive really little attention in the treatment, and that will eventually lead to, unfortunately, significant predictors of morbidity. If you can't treat someone's autonomic dysfunction, which is the dysregulation in blood pressure and heart rate, then they're going to be, unfortunately, wheelchair bound because they can't get up and walk, because they have trouble standing without falling, because they lose consciousness. So, see, these increase patients' risk for institutionalization. Most common symptoms that we see in Parkinson's, the motor symptoms, bradykinesia, which is the slowness in movement, rigidity, the stiffness, and postural instability, the gait and disequilibrium when ambulating. But there is a realm of other non-motor symptoms, as we see here. Autonomic dysfunction, heart rate and blood pressure dysregulation, mood disorders, cognition, pain, constipation, sleep disturbance, impaired smell, and other psychiatric conditions. The Parkinson's Foundation actually has a list of 10 early signs of Parkinson's, and as little as change in handwriting over the years may be seen again 3, 4, 5 years before we even see the motor symptoms of Parkinson's. So it's very important for a physician like myself or neurologist to focus on, have a wide range of approach rather than just my goal is to control the motor symptoms. So sleep and wakefulness regulation in the, I would say, normal adult, it's actually an active process. You know, you don't just turn the switch on or turn the switch off and go to sleep. It takes a stepwise fashion to prepare to go to sleep. There are multiple stages of sleep, as we see stage 1, 2, and 3, also called N1, N2, N3, are the first stages. So we fall asleep. How we monitor this is if when you go to a sleep lab and we place little electrodes on the scalp, we could actually monitor the waveform of the brain and see that a normal waveform is between 9 to 12 hertz. But then on stage 1, during stage 1 sleep, you could see that the waveform goes down to about 7, 8 hertz, then goes down to 4, 5 hertz. That's when we know patients are going through different stages of sleep. The last stage to talk about is REM sleep. This is when your body is completely paralyzed and you're dreaming. See, stage 3 and 4 sleep is the deep sleep where you're not, your brain is completely off. You know, you could still move your body here and there, but you're not really having any dreams. But the REM sleep is where you're dreaming. So when you're dreaming, you hope that your body's paralyzed because you don't want to be acting out your dreams. So, well, these are the normal wave patterns. And as you can see here, this is more of a this is a hypnogram, and it is a stepwise fashion, I would say. You are awake, you go to stage 1, then stage 2, then stage 3 and 4, and then we can, you know, get into a deep sleep within 40 minutes or so, and then we're starting to wake up again. Within about an hour and a half to 2 hours, we're in REM sleep, meaning we're paralyzed, but we're dreaming. And then that goes into back and forth stepwise fashion here. As a child, you are in deep sleep, of course. Your brain needs to be turned off. Your brain needs to develop. So, in early adulthood, that deep sleep changes. But interestingly, as we age, as you can see, we're not in deep sleep anymore. And what that means, we are waking up multiple times during the day. This is a natural phenomenon, natural thing that happens during sleep as we age. As you can see, in a 7-hour period, we can wake up 5 to 6 times. Sure, we can go back to sleep eventually, but what this really means is that when we age, we are more in a dreamlike state than a young child. We are in less deep sleep than the stage 3 and 4. We have decreased sleep efficiency, as we can see here. Look how many times you're being interrupted to just wake up in the middle of the night. You have more arousals, and you require more time to be in bed. So you can be in bed for 7-8 hours, but really only get 5-6 hours of sleep because you're waking up constantly. So what factors really modify our sleep patterns? So these are things like environmental temperature, if the room is too cold, if the room is too hot, drug effects. Patients that take benzodiazepine, which is like Klonopin for anxiety, Ativan, Versed, all these medications, it tends to even shorten the stage 3 and 4 sleep, deep sleep. So you're taking hypnotics to go to sleep, but you're really not going into a deep stage of sleep. And the circadian rhythm. So melatonin is a natural substance that we release from the pineal gland. It's a small little gland that's in the middle of our head. And when the sun sets, melatonin starts accumulating in our body, just increasing, and that's what sets us and puts us to sleep pretty much. So, with that said, you don't want the lights to be turned on in your room brightly. You know, you want to have a dark, quiet place. Take advantage of the sunlight during the day. You don't want to be napping during the day because your melatonin is completely off. You don't have melatonin in your system to go to sleep, but if you're napping, then your circadian rhythm is disrupted. You're sleeping during the day, not sleeping enough at night. So it's important to note that, especially with melatonin supplements, that when you take the melatonin supplements, you should really schedule it 3 hours, 2 to 3 hours before going to sleep, rather than taking it at 9, 10 o'clock and expecting to fall asleep right away, because it does take, as you can see, takes a few hours to peak. So that really takes us into our Parkinson's talk here. James Parkinson, he published the first essay in 1817 discussing the tremulous motion of the limbs that occur during sleep and augment until the patient awakens, and is frequently associated with some agitation and alarming-like signs. He's describing what's called REM, behavior sleep disorder, that became a diagnosis in 1986. So it took us almost over 100-something years to actually diagnose this. But in patients with Parkinson's disease, as you see, sleep disorders are very common and unfortunately have an immense impact in patients' quality of life. So Parkinsonism is a clinical syndrome that we describe. I'll use the term interchangeably: Parkinsonism, Parkinson's disease. So Parkinsonism are the symptoms of Parkinson's. Parkinson's disease is the most common diagnosis or common syndrome of Parkinsonism. So the frequency of nighttime sleep disturbance in patients with Parkinson's disease or Parkinsonism can be as high as 90%. So almost all of you here can have sleep problems related to the condition. And it could be two things. It could be related to the condition itself, or it could be a secondary effect, such as medications. So these are, unfortunately, as we discussed, are not really recognized by physicians, are not recognized by loved ones sometimes. I mean, we see it. Caregivers can say, well, you know, you can't sleep at night. That's not it's probably secondary to something else. But it is also part of the condition. So all of you will know that Parkinson's disease can cause significant amount of sleep disturbance. The most common sleep problem is, one of the most common is insomnia, inability to fall asleep. So this is mostly, patients frequently experience insomnia, often due to sleep problem maintaining sleep. So patients can fall asleep, but they can't stay asleep. And we saw why. Because in normal aging, we're constantly waking up throughout the night. So add Parkinson's disease on top of that, what happens is patients can't fall asleep because, unfortunately, they're having tremors at nighttime. How does someone fall asleep with tremors? They're so stiff that they can't get into the correct position to allow them to go to sleep. sometimes this mental relaxation, the inability to relax the mind, the medications wearing off during the period of the nighttime. So all of these are causes of insomnia and inability to maintain sleep at night. Another common cause is hypersomnolence. So complete opposite of insomnia. So you're sleeping during the day. Sometimes you can sleep at night, but mostly you're just constantly taking naps during the day. A big part of this is that one study from the UK looked at this and found that there is this hormonal peptide called hypocretin. And that peptide is actually extremely low in patients with Parkinson's. This is the same peptide that's been found low in patients with narcolepsy. Narcolepsy is a condition where patients can just suddenly fall asleep anywhere, either driving, they could be taking a test, they could be doing any activity, and patients collapse and fall asleep. So there is some connection that we're finding over the years that this hypocretin is also found low in Parkinson's patients, and that's why hypersomnolence or inability to maintain wakefulness during the day can be seen in patients with Parkinson's. What can we do about it? Well, adjusting the sleep circadian rhythm, making sure we try to stay awake as much as possible so we can sleep at night. Exercising during the day can definitely improve a person's energy. I'm just glad we're not giving this talk after lunchtime. That would be a problem. That would be a big problem. So this other most common condition that we see in the clinic is restless leg syndrome. How do you fall asleep when you're constantly finding the sensation or experiencing the sensation of crawling things around your feet, the inability to rest, constantly moving your feet and legs because you can't just rest them. And then all of a sudden when you stand up, the sensation goes away. That urge to move your feet and legs completely abates. So that's what restless leg syndrome. And it is a familial condition, but it can manifest in patients with Parkinson's years before they have Parkinson's disease. Now, if I have restless leg syndrome, does that mean I'm going to have Parkinson's? Probably not, but it's definitely a hallmark sign of patients with Parkinson's disease. They can have this for years before the condition. It's mostly associated with iron deficiency. Ferritin level, if checked, is usually low in patients with restless leg syndrome. So before trialing medications that will help with restless leg syndrome, trial our iron supplements. It's as easy as that. Iron supplements taken 3 to 6 weeks may help relieve some of the symptoms of restless leg. The issue with iron supplements, though, is, make sure you're aware, is it can cause constipation. And as we know, patients with Parkinson's disease can have constipation. So making sure you're taking a supplement to avoid constipation or prevent constipation when taking iron supplements. This is easily treatable. Here's the trick to this condition. Patients that take Sinemet, levodopa, carbidopa, typically will have some relief with restless leg syndrome, but it causes this augmentation effect. So you'll start experiencing restless leg syndrome during the day or later on at night. So sure, it helps a little, but it has some side effects with flaring out the restless leg syndrome during the day or at nighttime. So another medication, if iron supplements are ineffective, would be to actually trial actual dopaminergic medications. So discussing this with your doctor may help improve this condition easily. There are patches now, actually, with dopamine patches that patients can take because sometimes dopaminergic medication can cause some GI side effects, so the patches will reduce some of these side effects. REM behavior sleep disorder. This is often seen in 35% of patients with Parkinson's disease. Again, this is another sleep condition that can be present 2, 3, 5 years before the diagnosis of Parkinson's. Normal REM sleep is masked with body paralysis. So we need to be paralyzed during our sleep while we're dreaming of fighting Mike Tyson or Muhammad Ali. You know, we just cannot have the motor function during these dreams to be, because it can lead to significant problems such as punching and kicking, leaping out of bed, punching your partner, and interestingly, while we can dream in different stages of sleep, REM sleep in particular causes these vivid, bizarre, real dreams. Could be good, could be bad, right? Who's ever dreamt of falling off a cliff? And then all of a sudden, you wake up so fast because you are so close to that awake period. REM sleep is right close to the waking state. So as soon as, this is why you suddenly wake up, it's because you're not going from stage 4 of deep sleep into a wakefulness. You're going from REM to wakefulness. And you really, our body is created, our mind is created to suppress the motor function during this stage of sleep. Treatment is usually indicated, and symptoms can be controlled with small doses of medication, such as clonazepam, but I would usually start with things like melatonin. Those are helpful. Sleep disorder breathing is another atypical finding in patients with Parkinson's, because usually sleep-related breathing, such as central or obstructive apnea, this is where patients are snoring at night. Sometimes patients stop breathing while they're sleeping. So obstructive sleep apnea is typically seen in obese patients with large necks. And most of our Parkinson's patients are actually not obese. Now, obesity raises the risk of obstructive sleep apnea, so definitely dieting and exercising to reduce the weight may help with this condition. But interestingly, what we found over the years is that muscles around the neck in patients with Parkinson's can lose tone. Hence, when you're laying flat, it can kind of fall back into your trachea and compress the breathing, the vocal cords area, where that's why patients are snoring and don't have enough oxygenation. Now, if patients have obstructive sleep apnea, it will lead to strokes, cardiovascular disease, it will lead to worsening in Parkinson's, and eventually lead to the psychiatric components of Parkinson's. These patients are constantly sleeping during the day because they don't get enough sleep at nighttime, because they're constantly waking up because of the lack of oxygenation to the brain that arouses them. So it's critical to treat this condition. Treatment is very easy. You go to a sleep lab, you get diagnosed, you're placed on a CPAP machine. Now, some patients can't tolerate the CPAP machine, but nowadays they have different ways to administer the oxygen at nighttime, intranasally, through different masks. A trial of all these medications can help. So, what do we do in sleep disorders in patients with Parkinson's? So, sleep fragments, we know that sleep fragmentations can occur in patients with Parkinson's disease. So what happens is a simple adjustment in sleep hygiene can result in drastic improvement in sleep. So what are these sleep hygiene patterns? Sleep at a regular time. Schedule a certain hour where you're going to fall asleep, go to sleep, and the only thing you're doing in bed is going to sleep or having sex. But you got to just choose these two things. You can't go into bed and read a book or go on your iPad, just because that bed environment isn't scheduled or isn't arranged in your brain as a sleep environment. So making sure you use a regular time frame. You can't go to the casino and gamble on Friday and stay up till 2 o'clock and expect Saturday night you're going to fall asleep at 9. It'll take you days before you actually go back. Your circadian rhythm goes back to a regular pattern. I know it's frustrating, right? One night of staying up at night will result in taking few days to actually get your circadian rhythm back in place. Maintain a dark bedroom, quiet bedroom. Use bed, again, only for sleep or sex. Avoid late daytime naps if possible. Avoid alcohol, caffeine after a certain hour, depending on what time you sleep. Exercise, exercise, exercise. That's so important. That is so important in this condition. Now, exercise, any strenuous exercise, should be done 3 to 4 hours before going to sleep. Don't do it an hour before you go to sleep just because of all that endorphins and energy that you've created with exercising. Yoga, stretching exercises should be okay. Taking a hot shower right before going, or a warm shower before going to sleep, helps, because the drop in temperature after coming out of the shower may help put someone into a quiet, peaceful, and sleep state. And avoids stressful situations at bedtime. Just no arguments or checking your stock market at nighttime and stuff like that. Try to avoid that, right? Commonly used medications, melatonin, Seroquel, all these medications can be used, but without a good sleep hygiene, without a sleep study, we got to be very careful in using antipsychotics, because we know antipsychotic therapy can actually affect our dopamine level in our body. Well, we're trying to save as much dopamine as we can with this condition, so try to avoid any of the antipsychotic medications. But there are plenty of sleeping pills and sleeping medications that, including melatonin, with different dosages that can be utilized. And this would really take me to my second part of the talk, which, without enough sleep, unfortunately, patients with Parkinson's can develop worsening in psychiatric conditions. Now, Parkinson's disease alone can cause dementia later on, later advanced stages in life. Patients with Parkinson's develop panic attacks, anxiety disorders, social phobias. Imagine not having a peaceful and relaxing state of mind during the nighttime. That will definitely worsen patients' psychiatric conditions. So, as we know, hurdles to overcome here, cognitive impairment and their complication, don't really respond to medication as well. Don't really respond to the Parkinson's medications. So some minimally respond to antidepressants. I want to leave some time for questions, if that's possible. And I want to just go through things that we see, like dementia, depression, mania, anxiety and panic disorders are all seen in this condition. Compulsive behaviors. We got to be careful with compulsive behaviors in the sense of some Parkinson's medications can lead to compulsive behaviors, such as excessive gambling, OCD type of behaviors. So those medications would need to be adjusted, and sometimes just switching one dopamine to another dopamine would be enough. Psychosis. Commonly seen in patients, these symptoms mostly manifest in things like hallucination, visual hallucination. The most important thing here is that you got to talk to your doctor about it. Sometimes there's this stigma that I don't want to tell my doctor that my mouse or my remote control is turning into a mouse at nighttime, because I don't want my doctor to think I'm crazy. That's something that we need to overcome, and we need to make sure we share these thoughts, because if you are concerned or you're seeing things at nighttime, that will disrupt your sleep. And we need to either reduce some of the medications without having or avoiding the motor symptoms that can arise by reducing the medication, or we need to start medications that can help with these visual hallucinations. Sure, they can start benign. Takes few months to years until they start becoming that little mouse that you saw as a controller will start becoming a snake that's roaming around in the room. So these are important things to discuss with your neurologist and primary care doctor. There is a treatment that I recommend and use often, pimavanserin, which is an FDA-approved drug to treat Parkinson's patients with psychosis. What's a plus with pimavanserin is that it has been shown over the years that it's actually helping patients with their depression and helping patients with sleep at nighttime. It's a single dose that patients take. Again, only patients with psychiatric manifestation of Parkinson's. These patients are not receiving this drug because they're having sleep problems. There are many other ways to improve sleep habits before we go into eventually developing psychosis and all these other psychiatric problems during the advanced stages of Parkinson's. So to summarize everything, sleep hygiene is critical. Exercise with Parkinson's disease will help. Motor symptoms will help non-motor symptoms, boost the energy, boost the confidence in these patients, and it's critical to implement these very slight changes on a daily basis to hopefully avoid further progression in the disease process. Any questions? I'll be more than happy to answer. Is that okay? Yeah. Okay, good. Excellent. Go ahead. During the REM sleep, when it could be extremely dangerous to be close to your loved one when they're in that state. So if you don't think you're going to get hurt, it is going to be very easy to wake them up because they are very close to the waking cycle during their sleep stage. So I would recommend, especially if there's a close by nightstand or something that they could hit themselves and hurt themselves, it is definitely important to wake them up. Just be careful. Just let them know that this is a dream. It'll pass. Good news about REM behavior sleep disorder is that it has a flare-up sequence. So it gets really bad, and then there's an interval where it goes away. And then it flares up in a period of weeks, months, years. Sometimes patients just have one-time episode, and then it goes away. So during that stage, we would need to optimize medication, making sure they don't hurt themselves or hurt their loved one. So yeah, I think safely waking them up is okay. So do you see the sleep cycle? See the REM stage in old age? You see how close we are on the wakefulness? So it's really easy to alert someone during REM sleep. Now, if they're dreaming of it when you wake them up, I would be careful after they wake up because they would be upset. I'm just kidding. It's safe to wake them up. Oh, go ahead.
During the day, my wife sleeps all day. If I stop talking to her, she's going on. Does it hurt if I keep waking her up? Not every 5 minutes, but I make sure she gets her 9 or 10 hours sleep. Then when she wants to sleep during the day, if I can't get her to exercise, do I hurt her by waking her up constantly?
No, you don't. Let me ask you this. Does she sleep during the night?
No.
That's the problem. So what's happening here is there's a circadian rhythm problem. So she switched. So she's sleeping during the day and staying up at night. I'm sorry, but this is where you would slowly transition her, trying to have her wake up. It's going to be frustrating for a few days, but if we can try to keep her up during the day, first day I would start by letting her sleep. Instead of from 12 to 6, I would say, no, stay awake till 3, then you can go to sleep. Then the next day, stay awake till 4, then you can go to sleep. And transition that circadian rhythm from day to night and allowing her to actually sleep at night and staying up during the day. Depending on the medications, some of these medications could also be attributing to her.
I started giving her melatonin, but I give it to her before she goes to bed, so I just understand from you I got to.
That's right. Yeah, give it to her at 6 now instead of 9, 10 o'clock. Hopefully by 9, 10 o'clock she would be sleeping. But try to work hard in keeping her awake during the morning and afternoon so she could have the 9, 10 hours of sleep at nighttime instead.
No breakfast in bed?
You're very kind. It's okay. Breakfast in bed is okay since really you're waking up. You're not actually going to sleep. So good. All right, you're welcome. Go ahead, sir.
With medications like melatonin, it's something that kind of builds up in your system and works better after 3-4 weeks, or work like right away.
Yeah. So it's actually an opposite effect. So the question here, does melatonin take time to build into your system before you actually it starts being effective? So it's actually an opposite effect, unfortunately. Melatonin, if utilized, what's going to happen is if you're utilizing it every day, you're actually depending on this pill to be releasing the melatonin. Now, the pineal gland will still release some melatonin to help when the sun sets, but then your body's actually developing some type of very minimal tolerance to the medication. So the longer you use it, especially if it's every day, the more likely later on you would need to increase the dose a little bit and increase the dose even more. But utilizing melatonin, I mean, you could use it for years and it could be effective, and it should be effective within a few days, yes. Remember, melatonin is going to be almost like out of your system when the sun rises, right? Your body tries to get rid of it because technically you should be in a awake state now. Melatonin is going to try to put you back to sleep. So our brain is so incredible that it senses the light and it says, okay, melatonin, you're done for the day. We'll see you later on at night, type of thing. So, but no, I would be more than happy for you to be utilizing melatonin other than other medications out there, because this is a natural substance, a hormonal substance. Go ahead, Marty.
Can you please repeat the question into the microphone before you answer it until I get another microphone?
Yes, ma'am. She's so tough, this Marty lady. Go ahead, ma'am.
We found with the, not just restless legs, but the whole body herky-jerky sleep problem, that we take magnesium and calcium together at bedtime. You have to increase the dose gradually because of the effect on the bowels as well. But it does relax the muscles, and that's all we needed.
Excellent.
Magnesium.
Excellent. Thank you for sharing that information. So what we've obtained here is that magnesium, a little calcium before bedtime can mitigate or reduce some of the excessive movements that occur at nighttime. And it's interesting. So restless leg syndrome has another condition, another subcategory called periodic limb movement syndrome. And what happens is this can occur anytime at nighttime, during sleep even, constant shaking, constant movement. And what I've realized is magnesium, calcium, melatonin, and extended release, sometimes extended release levodopa, carbidopa can help reduce some of these periodic limb movement symptoms. By the way, insomnia related to stiffness at night, or related to tremors at nighttime, that you can't fall asleep, so you're staying up at night. Extended release levodopa, carbidopa, which you take before you go to bed, may significantly help reduce some of these sleep behavior or sleep problems. And it's only one pill at nighttime that you would take. Yes, sir?
You ever find any leg cramping? Is that anything to do with Parkinson's?
And so if the leg cramping goes away when you stand up and ambulate, that could be part of the restless leg syndrome phenomenon that's happening. So again, iron supplements, magnesium helps with leg cramping. So these supplements can mitigate this. Yes, ma'am. Sure. So usually, the pharmacies have different dosages over the counter, 5 milligrams being the most common, 8 milligrams. I tend to recommend trialing the lowest dose possible. Any doctor will tell you, you want to give the lowest dose that's most effective. So going half of a 5 milligram, 3 milligrams, if there's a 6 milligram tablet, will be sufficient to trial at nighttime for these sleep disturbances. Does that answer your question?
Yes,
All right, you're welcome. Go ahead, ma'am. Sure, sure. So the question is here, would CPAP help some of the REM behavior sleep disorder? So usually REM behavior sleep disorder is a disease in the pons, or the reticular activating system, which is in the back of the brain. Now, interestingly, the sleep apnea could be central. So it doesn't always have to be obstructive because of the collapse of the vocal cords or compression of the breathing tube. It could be central. And interestingly, central sleep apnea mostly originates from the brainstem. So can someone have central sleep apnea that could trigger or worsen possible REM behavior sleep disorder? I don't know, possibly. So trialing, first thing is getting a sleep study. I personally think every Parkinson's patient should have a sleep study done. Every Parkinson's patient, if there's 90% of Parkinson's patients have sleep problems, they all need a sleep study to understand what the sleep problem is. It's not like it's not like rare to have other sleep conditions and also have Parkinson's disease. So we need to make sure you rule out other things, narcolepsy, central sleep apnea, things like that, because then we're not really just putting a Band-Aid and calling this just Parkinson's related, and then hiding a bigger problem that can be just resolved with a simple CPAP machine. So to answer your question, definitely getting a sleep study, and that will help determine if a patient has central sleep apnea or obstructive sleep apnea. Go ahead, ma'am. That's an incredible observation there, ma'am. So the question here is, sometimes there's a feeling that there's something in an extremity that if I let it go, it's going to drop, but technically there's nothing there. And that's when we are concerned about early things of like psychiatric issues that could be related to this, the hallucinations, the delusions, the thought processes that usually manifest early on at nighttime. So that could definitely discuss this with your doctor, because there could be medication to help with that. You're welcome, ma'am. All right, thank you so much. Let me put the mask on. Thank you. Thank you all. Thank you.
let's keep it on time and start the next portion of the program. Welcome back. Hope you enjoyed visiting all the exhibitor galleries. We're so thankful for the exhibitors to be here, and we appreciate so much that you're learning and about their programs and participating in what they do. A reminder again that here we have this new beautiful edition, and welcome back to our virtual people who are seeing us on streaming and on Facebook Live. And I was just also informed, this is really good information, that this wonderful audiovisual team is recording today's seminar. So it'll be posted on the Empower Parkinson website when we're finished today. So if you wanted to go back and refer to something that you saw today, you will be able to do so. Or if you want to have a friend watch and learn as well, they'll be able to see this because it'll be recorded and on a link on the website on Empower Parkinson. So all good news. All right, a quick review again of the beautiful quilt. This is made by Beth Kosick, who is a rock-steady boxing boxer, a participant through Empower Parkinson, and she graciously made this beautiful quilt. It has the Empower Parkinson logo. It has the Parkinson's disease flower, the tulip, and we are going to be auctioning this off through a silent auction process. We have the yellow sticky notes on your table. You can put your name, your phone number, and your bid on there, fold it over, and then at the end of the program today, the volunteers will have, in the burgundy t-shirts, will have burgundy bags, and you can put your bid in there. We do, as I mentioned just a moment ago, already have a $500 bid, which is amazing, amazing. And if you're willing to go above and beyond that as a donation to Empower Parkinson, please feel free to do so. All righty, so working through freezing. Now we are on page 42 in the book, if you'd like to follow along and take some notes. And we have the wonderful Julie Lombardi and Liz Horton. They are returning to the stage. Of course, they were doing all these fabulous exercises with you a moment ago. And right now they are going to be talking about working through freezing. And by that, of course, we don't mean air conditioning. We mean some of those gait issues, et cetera, that you and your caregivers are muscling through. And we appreciate that so much. They're going to tell us more. Please help me welcome Liz and Julie again to the stage.
All right. Hello, hello. So I am Liz, and I'm going to be leading it off, and then Julie will be taking over at the tail end, and we're going to be talking about freezing of gait. So the things that we'll be chatting about today is what is freezing in Parkinson's, and why does it happen? And then we're going to go over some treatment strategies, so some things that you can be doing to help stay moving. So the definition of freezing, it is a brief episodic absence or marked reduction of forward progression of the feet despite the intention to walk. So often what I hear, sorry, I'm being cued that I'm too short. So often what I hear in the clinic is it feels like my foot is glued to the floor, or it is so hard to get my foot to take that first step. This typically will last for a couple seconds, and then people will be able to move through that. But for some people, it can take a longer amount of time, and they may even need to use compensatory strategies or cues that we'll go over today to help them get moving. Freezing can happen when you're trying to start your walking, when you're walking or turning, and it can be that you are trembling in place. So it could actually feel like your knees are shaking a little bit, or they may buckle. It can be a complete freeze, like you are just stuck and not able to move. Or it can be that shuffling, like your feet are sort of a runaway train. Freezing is so common in Parkinson's, and it happens in about 63% of people with Parkinson's. And freezing less common, we see it in the arms, and then you can also have freezing of speech. We won't chat about that today, but that definitely can be part of freezing. All right, so Mark, can you play the video? Perfect. So this is someone with Parkinson's during their off time. You can see their short stuff, their little shuffle there. They get stuck during that transition and flooring. Those teeny tiny steps, having a hard time starting their turn. That inside foot for that turn is just having a really hard time. He's having a hard time weight shifting onto it to get that turn going. So this may look really familiar to you. This may be, how you feel you move sometimes during the day. And then this is the gentleman, he's coming to a doorway. So often there are environmental factors that play a role in freezing. So changes in flooring, like going from hardwood to carpet, or going through a doorway, or hitting a threshold. All of those can be triggers. All right, Mark, I'm gonna have you pause it for me. Thank you. And in turning, we often see the whole body moves together. There's not a lot of rotation, and you can have your feet moving a lot quicker than the rest of your body. Mark, can we go to subtypes of freezing, please? All right. There are 3 different types of freezing. There is the movement or motor type. There is the cognitive type. So motor would be freezing while you're turning or freezing while you're starting to walk. Cognitive would be freezing while you're doing 2 things at once, like walking down the street and thinking about what you're gonna make for dinner later that day, or your grocery list. And then also the limbic system. So freezing when you are feeling anxious. And that can be, you have a doctor's appointment and that you are feeling rushed trying to get there on time. There can be specific triggers for freezing, and everyone is different. So, what may be a trigger for one person could be completely fine for someone else. And so just some examples. So the motor can be turning, coming to a chair, trying to move in small spaces. So like between your coffee table and your couch. Again, moving with changes in surfaces or doorways, and that first step. So once you get standing, that first step. Cognitive or attention can be walking and talking. Doing multiple things at once, like walking and trying to open up a bottle of water. Or walking and say it's Wegmans on a Saturday morning where it's so busy and lots of things to be paying attention to. And then the limbic or anxiety is feeling rushed or anxious. Some risk factors that have been found that can lead people to have more freezing of gait. It is thought that left-sided involvement, so if your symptoms started on your left side, that may lead you more towards freezing. And the idea behind that is that the right side of our brain is really in charge of processing movement and sensory information. If your symptoms began in your legs, or were walking symptoms, if your symptoms are more related to trunk, maybe trunk stiffness, rigidity, slowness of movement, if you are needing to take a higher dose of levodopa, great talk this morning about sleep issues. So if you're having sleep issues or having cognitive or thinking issues, poor balance, and presence of falls, that runaway train gait fascination, hallucinations, depression, and anxiety. And there are multiple pathways. So freezing of gait doesn't just impact one specific circuit in your brain. There are multiple pathways that that we think really impact your ability to initiate and move. And so just to go through them, let's see. Nope, too far. Okay, you can't see that. Okay, so the first picture is just the connection between the basal ganglia, that part of your brain that's impacted by Parkinson's, and the brainstem. And that connection impacts the rhythmicity of our movements. And when that communication gets disrupted, it's harder to have that rhythmicity of our natural walking and coordination. The second brain has to do with areas in our motor cortex. And when that and our basal ganglia have a hard time talking, it's hard to initiate movements, especially things that are pre-planned or that we've had lots of practice doing in the past and walking. That third picture is the areas that are in charge of our brain that help us with posture. So when those areas are having a hard time talking to our basal ganglia, our posture has a hard time making anticipatory changes or adjustments to react to getting moving. The fourth brain picture is our perceptional areas of the brain. And so where that plays a role is when we come into a tight space or there's changes in flooring. That's what's triggering the freezing. And that fifth brain has to do with our executive function, our higher level thinking. And that would be having to make a decision with our movements. So you may stand up and think, what foot am I going to step with to start? And that having to make a decision between two things can get us sort of stuck. All right, and so why do people experience freezing? So it can be a multi-factorial thing that happens. So these small things add up and end up with a freeze. So one of the big ones is changes in our walking pattern. So that can be asymmetries between our steps and our weight shifting or step and coordination. It can be issues with how we are processing our visual and auditory information. And then changes in our posture. So you may have seen in our big exercises that we were up big. I was cueing you to be big. So posture can play a big role in freezing. Perceptual intake of information, again, like getting through a doorway, being able to figure out the spacing between furniture can be a trigger. And then also being able to figure out or think through conflicting information. Standing up, should I start with my right foot or my left foot? And then that anxiety component. So if you are feeling rushed to get someplace, and oftentimes that cognitive, so that thinking piece of having to decide between right and left to get going, or any other decision making, and then that anxiety piece, feeling rushed, can really create some overload in how our brain is able to process information, and then it's not able to come up with the movement signal at all. And so next, Julie's going to come up and talk about ways that we can work on treating freezing.
Right, so I'm going to get into the more of what do we do about it now? Liz talked about some of the cues that we use, so we'll kind of get into more depth about that. So there are medications that some physicians will try and different medical treatments that some physicians will try, and you can talk to your physician about. Cognitive behavioral therapy, yoga. I'm a big advocate for physical therapy, occupational therapy, and speech therapy. And then there are different types of cues that we can use. So we put this slide in. This is not our area of expertise. This is information for you to kind of look at, and you could discuss with your physician, okay? Because it's talking about different medications that are sometimes used and being studied for the treatment of freezing of gait. And then some of the things that are not pharmacological, like spinal cord stimulation, deep brain stimulation, and also still something being researched is transcranial magnetic stimulation or vagus nerve stimulation. So that's in there just so you kind of know about it, but it's more for a discussion with your physician. So cognitive behavioral therapy, when we are evaluating patients and we look at certain things in the clinic to try to come up with what are your triggers, what's causing you to freeze specifically. And when we start to pick up on pieces and you start to tell your therapist things that sound like anxiety might be part of the trigger for you, that's when we start to have the discussion of, well, maybe you should be talking with a licensed therapist about some of your anxiety to help calm down the nervous system. So this is a nervous system disorder, and if we can calm down one of the pieces that's causing or contributing to your freezing, then it can help you with that freezing. That's the same kind of basis for yoga. So yoga helps to calm your nervous system down, helps to get rid of some of that fight or flight type of mechanism. And it's been found to be helpful with anxiety. And if we can help with the anxiety, we can possibly help with the freezing. So physical and occupational therapy are huge for anybody who's having any freezing. So again, when you come into the clinic, we would evaluate, how do you move? Let me put you under different circumstances and see what are some of the things that trigger you specifically. Do you have that motor piece like Liz was talking about? Are you somebody that when you try to turn, your feet get glued to the floor? Or are you somebody that when we get near a group of people and you start to feel like you're being rushed, you start to freeze? So those are the types of situations we put you in to look at what are your specific triggers and then try to figure out what are some of the cues that may help you. And a big key to this is when you start to participate in therapy, repetition is really important. High intensity, a lot of repetition is really important for your body to learn how to change how it moves. So anytime there's something that is brain related, your brain has had so many experiences repeating what you don't want it to do, right? Making you freeze. You've experienced that over and over and over again. We have to kind of undo those learned behaviors as much as we can. So we end up seeing people a lot in the clinic, like frequently. It might be 3 times a week or 4 times a week, and at first at least. So some of the things that we do, so your therapist might put you on a treadmill, and we have found in research that a long duration on a treadmill can help. Sometimes we speed it up just a little bit faster than you're comfortable with, or it might just be right at your pace. And the rhythm of the treadmill, it forces you to move at a more consistent speed. So your body's getting high repetition at a consistent speed instead of that shuffling that you get or those asymmetrical timing that you might get when you're just walking on the floor. We also might do things like use a cue while you're on the treadmill. Put like a large ball in front of you that you have to kick over and over again. Because one of the things we see when people that have this disease is that if we give you something outside of your body to reach to or to get your foot towards, all of a sudden your movement can be a lot bigger. And so that repetition of that bigger movement, again, it kind of just reinforces and teaches your body to start moving bigger. Now, we also will work on things like balance and coordination, because if you're having issues with balance and coordination, then you're trying to walk and balance. So your brain isn't really freed up to just walk and think about walking. You're also having to think about balancing. And that goes back to what Liz was saying about some of the executive functioning, where it's hard to do two things at once. So if you are having to think about balancing or coordinating, carrying something while you're walking, you're doing two things at once. And if that's hard for you, it can cause you to freeze. So some of the strategies that I try with people. So we evaluate you, what situations you get freezing, and then we go, okay, what strategies work for you? And it's a trial and error method often. Try a bunch of stuff, see what works best, and then kind of stick to those things. So one thing is to separate out your tasks. So if you were gonna go walk and pick up a box and then turn around and walk and put that box somewhere else. So we all do that in our daily lives, right? Like I just walked, pick up a walker, came up here, and then had to get started here. But if I had freezing, I might benefit from going, I'm gonna walk, I'm at the walker, I'm gonna stop. Now I'm gonna pick up the walker and stop. Now I'm gonna turn and stop. Now I'm gonna walk again. So it's inconvenient, but it can be a strategy that can stop you from picking up the walker and then as you're turning, falling over. Taking wide turns. So a sharp turn, as you saw in that video, when you try to do a sharp turn, often the foot that's to the side that you're turning to, we often see people don't weight shift over to that foot. So if you can kind of do a wider turn, it lends you to weight shift a little bit more. So that's a strategy that can work, especially like walking in and doing an elevator and doing a wide turn there, and just learning that in general you're looking for opportunities to do wide turns. We'll again help you know your triggers and know what strategies help you the most. We talk about staying calm. I do a lot of breathing with patients. Sometimes when we first get started, we put on a breathing app that is just like a kind of a calming Zen sound, and we breathe together, and then we start moving and breathing together. And the whole point of that is really just calming the nervous system again. And I often will recommend different types of relaxation meditation apps, again, to calm that nervous system down, especially in the morning or at night before you go to bed. In the morning before you have to start moving, you do something like that to help calm everything down, to help with the freezing. And then another great strategy to help you stay focused on your walking is to count your steps as you're walking. You know, we'll say, I need to get from here to that stairs. The stairs, I think it's going to take 10 steps. I'm going to count each step out loud, and that helps me keep my attention on one task of just walking. Now, we talked about there's a motor subtype, the limbic subtype, and the, I can't think right now, the cognitive subtype. That was very appropriate. So with those three I don't really think I've ever seen anyone that was just one category. So most people that come in have a couple of things happening there. So, you know, if you're somebody that has some of that cognitive subtype, difficulty doing two things at once, at first we might say, and I've said to patients, okay, no talking while you're walking. Like for now, you're focused on walking and how you walk. So if you're with your spouse and they start talking to you, it's a great opportunity to be like, sorry, we can't talk right now. I'm just gonna walk. And also the spouse can remind them, like, let's just focus on walking. And again, trying to count each step. Mental imagery and watching movement can help. I have had patients take videos of me or somebody else walking with big movements so that they can kind of watch those videos before they get out of bed in the morning, if it's somebody that has a really hard time getting up and moving in the morning. And I've had patients tell me that it's so helpful. If I watch you walk for like a minute before I get out of bed, I can get up and walk. And sometimes pairing that with sound can be even more helpful. Am I there? Okay. Other strategies, little things that sometimes help. I've been using this one a lot with some of the patients that I have right now, is just reaching to shift your weight. And so, and again, it's important to work with a therapist, because I might have somebody do a really big reach, but if their balance isn't good enough on this leg, some people, you know, they reach and they shift their weight. If you see me, if I reach this way, this leg is now free to move. Sorry, I'm trying to show, and if I shift my weight far enough, it frees up my other leg to move. So then that can help with that freezing of gait and getting that first step to start. As Liz was saying, posture can really affect some of this. So a lot of people with Parkinson's get really stuck in this forward posture. And when you do that, now your weight is pulling you forward and your feet can't keep up to it anymore. So we teach people, stop. You're gonna reset the system. Stop, stand tall, get your posture back up again so it's not pulling you. The weight of your upper body isn't pulling you forward anymore. And then taking a big step. Just thinking big step can sometimes be enough to get you to start walking again. We talked about breaking down tasks into one step. You can tap a leg, like this leg, go. Saying go can sometimes help. Looking ahead at a destination in one spot might help, especially if you look ahead and then you count how many steps to get there. Taking those wide turns. For some people, thinking about running, because it just kind of gets your motor system going, all right, I have to take a bigger step than I was thinking of, I have to run, and it also helps to kind of move it to the movement initiation to a different area of the brain to get you to be able to move bigger. And then for some people, it's like kind of counterintuitive, because usually we think, oh, with Parkinson's, people are too slow, we need to speed them up. But for some people, they need to slow down. So often with freezing, everything's too fast. They're talking too fast, they're thinking too fast, they're walking too fast. We need to slow it all down to get some rhythm, slower rhythm pacing back in there to move with better movement. So we're changing the focus of your attention to your steps. When we're counting steps, we're allowing you to generate movement from cortical areas rather than the basal ganglia, where that's where automatic movement comes from, but that's the area that's affected with Parkinson's disease. And again, once you free up that system for walking rather than worrying about balancing and talking, you can prioritize your focus on walking. So visual cues have been found to be very helpful. So if you guys have seen anyone using like lines on the floor or, oh, did I miss the video? I missed the video. Okay. So sometimes you can put lines on the floor to help cue you to take a bigger step. And that's where some of these devices that we have can be helpful as well. So I'm going to show you this U-step walker. So it's hard to see up here, but if you wanted to see it during a break or something, I'm sure my friend would show it to you. There's a laser light on the floor with it, and that is a cue. So if I'm having a hard time walking and my feet get stuck to the floor, if I have my laser light on, and this walking pole, Liz has the Next Stride device attached to it, which also provides a laser light, which you can see a little bit easier. If that light's on, it's a cue for my brain to step to that. So that's an external target that's helpful with freezing. So she's stuck, she stops, she looks at the light, and she can step to it. All of a sudden, the brain gets going again, and you can walk with big steps. You can use painter's tape if there's like a certain area in the house that's hard to walk through. You can use that as lines as well. We often use metronomes, so we're getting that rhythm going again. And this Next Stride device also has a metronome on it. So if you can hear that, you may not be able to hear it from up here, but it is nice and loud. So just like a metronome that you would use for piano or something, there's different speeds. So working with your therapist, you figure out what speed helps me get into a safe rhythm for walking. You can turn that on and just walk to the rhythm. This can help to normalize your walking speed. Other internal cues might be like you can sing. A song that's like really familiar with a very familiar pacing is Row, Row, Row Your Boat. And there's been a study looking at that. and they found that singing to yourself, Row, Row, Row Your Boat, and trying to stay in time with that can be helpful with your walking. So this is just listing some apps that are available that you could download so that you can have your own metronome handy in your pocket. Some of the devices, so Liz just showed the Next Stride as an attachment And if you were to use a discount code from Liz's practice is Engage Physical Therapy and Occupational Therapy and Speech Therapy, and if you use the discount code that she has, you can get, is it $100 off of that device. And that can attach to a walker, a cane, walking sticks. That's why you were asking about that. So yes, this slide has that information about the next stride on it. And then, of course, we have to talk about home safety. Just, this is a slide you can, I think we're short on time here. So this slide just has basic things to think about with home safety. And then there's our references. Do we have time for any questions or no? No? Okay. If you guys can grab one of us later if you have any questions on any of this. But again, please get into, if you have Parkinson's, you should see a physical therapist and get established with a physical therapist. Even if you think you're moving just fine, we'll most likely be able to find something to help you with. Thank you.
Thanks so much, Julie and Liz, and they are sitting right here, so if you're willing to take some questions, ladies, please put your mask on, come over and ask them some questions, because that was a lot of good information, really important information. And you saw on the slide that on page 53 was the discount code down there if you're interested in getting one of those devices. The metronome on the walker, very cool stuff. All right, it is time for lunch, ladies and gentlemen. So the lunch will come to you. If you're joining us virtually, take a break and we'll be back here at 12:25. Please put your mask on if you're heading out to look. The exhibitors will be open during this break. The bathrooms, of course, are available, but the food will come to you at the table. Take this time to meet people around you and learn from them, because there's really nothing better than learning from someone who's going through something similar. And thanks so much for your attention. Enjoy your lunch. All right, everybody, it's time to get started with our after lunch speeches and information session. Hope you all enjoyed your meals and had a good break meeting with everybody. Welcome back to everybody who's joining us streaming live and on Facebook Live. We're so thankful that you're back and learning from us today. Thanks so much to the Wyndham crew for a wonderful lunch. All right, many of you out in the audience here, virtually and live, are dealing with Parkinson's, and maybe even a greater number of you in this room today are actually the caregivers of those dealing with Parkinson's disease. It's a big job, and our next speaker is going to focus on you, the caregiver. Taking care of yourself, so important, while taking care of others. With over 40 years of home care and geriatric specialization, Becky Auer is knowledgeable about the challenges facing the aging population, passionate about assisting them and all of us to age well. She received her Bachelor of Science degree from Ithaca College, is a licensed physical therapist and advanced professional with the Aging Life Care Association. In addition to holding a care manager certification through the Academy of Certified Care Managers, she's a certified dementia practitioner. Becky created her own practice called Inspire Care in 2011. Inspired by the care and advocacy she provided her mother for 25 years as she was dealing with Parkinson's disease. You may have met Becky at one of our previous conferences, and we're thrilled to have you back again. Becky's a recipient of several awards. Most recently, she was recognized as a COVID-19 Resilient Response honoree by Center State CEO, as a company that continued to provide client services during the worldwide pandemic. Currently, she serves on the Professional Advisory Committee for Hospice of Central New York and the Finger Lakes. Becky, welcome back to living an active life with easy for me to say, with Parkinson's disease. We're so excited to have you here to learn more about how to take care of the caregiver. Please help me welcome Becky, won't you?
Well, I do have the job of making sure that you're waking up. Dr. Saada said he was glad he didn't have this position, and I wanted to say, I've got it. I am the one that's supposed to make you awake and keep you going. So I hope that you're going to stay with me today. Thank you for the introduction. I have been proud to be a sponsor of this Parkinson's conference since day one. 9 years ago, Inspire Care was just starting, and we were able to sponsor the conference. And since then, it's been just a joy and privilege to be part of that organization. I would like to say that the reality of caregiving is a topic that is very near and dear to my heart. I am a professional physical therapist, as was told, but also I would say primarily I'm a caregiver, and I have been for many, many years. It's estimated right now that there are 41.8 million caregivers. Now that's a lot of people in the United States providing care. And it has escalated by 5 million over just 5 years. I think we can see the trajectory of caregivers, and I know we have a lot of them here. I'm going to use this to change our slides here. Our discussion points today will be personal caregiver stories. I've got some personally that I'd like you to hear, because I think personalizing the caregiving role is very important. You all could come up to this mic and have a lot to say, I'm sure, and hopefully I'll connect with you through my personal stories. There are 7 positive caregiver habits, and people say, oh, Becky, I don't want to start a new habit at my age and my stage in life. But you know what? Starting one new habit and learning about a new habit today will be so helpful going forward as a caregiver. Professional caregiver stories, I've got lots of those after 40 years of providing care to Parkinson's patients and their loved ones. So I want to provide you with some of my professional caregiver stories, always end with final thoughts and some questions as well. So let's move on to those personal caregiver stories. The first story, and if any of you were here 4 years ago, I was able to talk more about my own mother. I am a physical therapist, and thanks to Mom, I say Inspire Care was born. She had 25 years of gracefully aging with Parkinson's disease. And in the realm of things, that's quite a while. And I would say my primary caregiving role started from the first appointment. I took her to the first neurologist appointment. And you know, when I see the symptoms, but she doesn't, it was like pulling teeth to get her to go to that appointment. But I knew we needed to start the professional oversight of her care. We walked away without medication. They just said monitor it. But from that day on, I was the primary caregiver. Even though she didn't live with me, I was raising a family. My dad was the primary caregiver in the home. But you know, when you're a professional, you're always going to be caregiving and watching. And so I did that with my mom. But you know, I learned from that experience that it was often the best thing I needed to do was to give over the caregiving role. I don't know about any of you. I went to every single appointment because I wanted to write down and be the scribe for all that was said. But you know, the first time I gave over that role to another individual, I let a friend of mine take Mom to a doctor's appointment. Well, she came away, not only was my mom bright, smiley face, she'd made a new friend, she contacted this woman thereafter, she trusted her explicitly, and you know what? I learned I needed to step back and not do it all. We can do it better when we have help. I'm so sorry that this little cartoon doesn't have the saying and what the caption should read. And do you take Goldie to be your lawfully wedded primary caregiver? Don't you sometimes feel that way, caregivers, that you were wedded into this? It may be that you're actually married to the person, but maybe a fact is that you're caregiving for somebody that's not in the area with you, but you're still wedded to them. I think it's very, very interesting how we start our caregiving roles. And my mother-in-law, I would say this caregiving personal story is actually about her. Let me just see where we are. I'm going to stop right there. I went one back. Let me see if my back button works. There we go. I'll stay right there. The thing about my mother-in-law, who I love, was that she made a promise to my father-in-law that he would never go into a nursing home. Now, I don't know about you, but those are promises that sometimes are very hard to keep. But my father-in-law had a progressive condition that warranted lots of care in the home. She didn't have anyone living with her. They'd moved to North Carolina. She didn't have any of her 5 children near her. But the situation that my mother-in-law found herself in was increased care needed and no one around to help. And I found that the promise that she made layered a lot of guilt on her, that she had made this promise and she wasn't sure she could keep it. But I think what we all found out in the family is that we were challenged together to come and be those caregivers for my mother-in-law so she could take a break. So even though Nani made that promise, she did keep him at home, and that's what we wanted all for her. My third story, personally, is about a great friend of mine whose mother lives here in Central New York, and this friend actually lives in Eugene, Oregon. 13 years ago, her mom was diagnosed with a progressive condition that warranted a caregiver. Now, I don't know about you, if you're here caring for someone or if you're here as a caregiver looking for information for a distant person that you're caring for, but she sacrificed her own marriage, her own family. She moved to New York, was here many months out of the year, and went back and forth to Eugene, Oregon, taking care of her mother. I am so proud to say that right at the end, she was with her mom on the last breath that she took. But you know what? The dynamics of families, and you all may attest to this, are very challenging. We all would like to say that everybody is looking at the situation the same way, everybody's jumping to and helping. That doesn't always happen. In this situation, though, I found that her abilities to draw in from the resources in the community really helped make it a better situation. But you know what? If she had learned that there were 7 positive caregiving habits and learned them early on, I think she would have done so much better and felt more supported. So now let's look at some of these positive caregiving habits. You know, we are all told when we get on an airplane, and if it's like me, I haven't been on one in a long time, but don't we have to put the oxygen mask on first before we help the person that's with us, whether it's a child or someone else, the seat beside us? I think the same thing with you caregivers who are here. You need to take care of yourself first so that you can do the job well of taking care of your loved one. The other thing is I see those cross signs of support and direction, and so often I'm finding well-meaning individuals fed to me what they thought I should be doing. Any of you hearing some well-meaning advice? And so much coming from all different sources. It could be our families, it could be people in the community, it could even be coming from church where you want to get uplifted. But I think what we have to realize, everyone has an opinion, but in taking care of yourself, you're going to land on those aspects of these caregiving habits that really work for you. Positive caregiver habit number 1. And the exercise you're going to do is take out a pen, please, for me. If you don't have one, I want you to get one in your hand, especially if you're the caregiver. And what I would like you to write down, here's your homework, is I'd like you to write down just 2 things that would make the experience of caregiving easier for you. 2 items, 2 things, 2 activities, whatever it is, that right now pop right into your head that would make caregiving easier. If I was Jeopardy, I'd have that sound going back and forth, but just write down 2 of them, please. So often, I think one of the barriers to having asked for help is that we're caregivers. We give, we don't take. And so I think as a caregiver, predominantly, it's a very challenging role to have. Making a list of your needs, just like what I asked you to do, is very, very important. And maybe you've done it before and you say nobody even is there to help. But you know what? The more specific you are in your needs, the more help you will get. What about taking the garbage out on Monday nights? Maybe it's picking up medications twice a week. There are so many very specific roles during your day, and I think that if you are able to ask for those very specific needs to be met, there are those in the community and in your family that will rise to the occasion. And I think sometimes, often, we feel very sorry for ourselves. You know, as a caregiver, I don't know how many times I laid my head on the pillow and thought, I don't think I can do this one more time. It's very challenging. And I think those that we're caring for may not always appreciate all that you're going through as you're providing that care. But being grateful for the small things that happen during the day. I started a gratitude journal. It made a huge difference beside my bed that I could write down one thing even that I noticed was a positive in my caregiving experience. Right now, I'm blessed to have 8 grandchildren, one on the way, 9, and one of our families has a routine of saying, what are your roses and what are your thorns at the end of the day? And I think caregivers, if you can write down what are those roses, those very positive things that happened, and maybe there's a thorn, write it down, and then set the paper aside. I think it's so helpful for us to reflect on gratitude. Identifying a circle of support, oh my goodness. You may feel like it's very small, but having a trusted group of friends, it might be a Parkinson support group, it might be some other organization that you belong to. Having that circle of support will help you to ask for help. All right, let's move on to our habit number 2, get organized. Oh, people say, Becky, how can my life possibly be organized with all the time I have to spend in caregiving? I think, again, making a very small inroad into the task of organizing and prioritizing. Are your advance directives in order? Do you have your will updated? Some of the small things, and just one, may be something that you need to add to your list to be well organized in this caregiving role. And I think the other thing I've written down here is to just realize it's an imperfect road. Maybe the organizational skills are not yours. Maybe keeping the calendar is not something that you do comfortably. But you know, I do believe that though someone else's road of this caregiving might not look the same, you have to realize if you were to have waffles tonight for dinner, really, who cares? Who's watching you, right? Give yourself the credit that there was dinner on the table, whether it's breakfast, lunch, or dinner, correct? My habit number 3 is let's take some daily breaks. I don't know how about you, but it's hard to find even a small bit of time in your schedule to have a break. And I think if we're able to look at the scheduling of what I call respite care. Now, to some people, respite care is a full week. Maybe you're going on vacation. Sometimes it's actually 30 minutes. That's respite. That's giving you a break. So I think it's really important. Those small windows, dedicated small windows of personal time. And I've had others tell me that connecting with nature is something that changes their whole perspective. They have a different view on life if they look out the window. You know, Central New York, I don't even want to say the S word, but we're headed that way. There's great beauty in snow on the horizon. There's great beauty in leaves outside of our window. And I think for the caregiver as well as for the one you're caring for, get over by the window, go out on the deck, spend a little bit of time outside and you'll be blessed by it. This saying on here that wrinkles will only go where smiles have been. I don't know about you, but I'm getting more and more wrinkles with the years that go by. And if I can tell people that's where my smiles have been, I think it labels those wrinkles well for what we've done. How about caregiver habit number 4? Maintain and start hobbies. You know, this is one of those areas where I think a caregiver ultimately says, I'm in it for my loved one. I don't have time to start anything new for myself. Well, I've had so many of my wonderful, not only personal, but also my professional caregivers that have been able to add something to their day. One woman in particular decided her mother, who was in her 90s, who played the piano, would not play without somebody there. So this woman took up the ukulele. The ukulele is small, it's compact, it doesn't take long to learn, and she found that if she got her ukulele out, her mom would walk with her walker over to the piano, and lo and behold, they have a duet going on. It doesn't take much, and I think you might realize that you've learned to do something new in the process, and it's brought you joy as well. So think about a habit that was an old one. Maybe it's crocheting or knitting. Think about something that you might try that's new. Number 5, join a support group. You couldn't be in a better place to find a support group than where you are right now. And I'm going to encourage you that you not leave here without identifying a support group that you as the primary caregiver could be aligned with. You know, COVID had its good and bad points. I think one of them was Zoom connection. Those individuals who found it hard, no matter what time the support group was being held, to get out to the support group. It never was the right time. But I have found that people are able to turn on their computer, catch a little bit of it, be part of it. And so I think that is one of the positive things of COVID that I have found. But just what's happening today, this to me is a support group. I find that the connection of all of us being together and learning about the path that we're taking can only uphold what the caregiver is trying to do. So join that support group. Utilize community resources. How about considering separate support groups for the caregiver as well as for the Parkinson patient? I think that we have a need to have both. And if you can prioritize your time, you might find that there's an old organization, maybe it's a singing group, maybe it's an instrumental group that you've been part of in the past, would be very helpful to you. And I think an accountability partner, I don't know about you, but if my feet are held to the ground that a decision I've made is going to actually happen, then I'm sure to get it done. Having one person that is a trusted friend, a trusted accountability partner, and it may not be your loved one that you're caring for, but somebody that has a little bit of understanding of what you're going through, bring them into the fold, tell them, I need you to call me and tell me to do X, Y, and Z. It's amazing when you have somebody walking beside you during this caregiving role that is so important. So accountability partners. We've heard a lot today from our exercise gurus, and as a physical therapist, I couldn't agree more that movement and exercise is often better than medicine. It's something I've said for 40 years plus as a physical therapist, and I do believe that the caregivers need to incorporate that for themselves. Let's look at some of these. I'm talking about eating healthy, exercising, cooking. Something new in the kitchen would be a great thing for you as a caregiver for your own health and well-being. Meditation, prayer, something that would focus you on the task ahead. It can happen in the morning, at night before you go to bed. How about music? Oh my goodness, music is not only great for the Parkinson's patient, but for the caregiver as well. I see buds and headsets on people all the time. I think floating music in your home can be a wonderful uplift. So if there is a playlist that just brings a smile and therefore more wrinkles to your face, put on that music for you as well as for your loved one. And finding a quiet place. I think it's so necessary. I have a chair, and I don't know what's going to happen when the upholstery gives out. I'm going to have to recover it, but that's my quiet place. It always was when I was caring for my mom. It's a place where I can not only come and center on the needs that I have for the day, but it gives me my own spot. Find one in your home. I think it's really, really helpful. Let's go on to our last one, because I said there's 7. Positive caregiver number 7 is building caregiving skills. You know, it's so easy to just go day to day and not realize that the more you know about the condition of the person you're caring for, the more armed and prepared you are. And so I think coming here, my goodness, those of you that have been coming year after year, or even if you're new to this and you're going to come back next year, it's a great place to learn more information. Dr. Saada presented years ago about delusions and hallucinations. He presented today about sleep patterns. I think gathering all that information is really helpful. What are some other ways? There's hospital classes. There are other ways that you can learn about Parkinson's online. There are mentoring supports. Have you connected with one person who's also walking through the Parkinson's world that you can connect with? I think that would be very, very helpful. My number, if you want it, I'll be glad to be a mentor and a help. So feel free to connect with someone there. So we've got 7 habits, and I think it gives you confidence. It gives you a better scope and feel for life and what you need to do for yourself. But I do believe that all of these caregiving positive habits, let's bring them up again so that you know. I'm reminding you of all the ones that are on your handout to take home. You know, I don't want this talk to be just one more that's overwhelming in your task of to-dos. I really had hoped it might be something that was informative but different, that might give you the encouragement to step out as the caregiver and really prepare yourself for tomorrow, because it really is one day at a time. Because I'm a physical therapist, I find that goal setting is really what helps me to stay focused. What if you, as the caregiver, had one goal that you would establish for maybe the next 2 weeks? What would that goal be? Can you think of one that would be helpful? Maybe it's something that we've talked about today. Maybe it's an accountability partner. Maybe it's taking a break to walk around the block. I'm going to have you take that pen out. You wrote your 2 areas that would make caregiving easier. Now I want you to write one goal down, just one, that you could focus on for the coming weeks. One goal. And I found that goals can only be attained if there are manageable interventions or steps to take. If it's too overwhelming, lose 10 pounds. Oh my goodness, where are we with that? We'll never get it done, right? But if you have manageable small steps toward each goal. So let's say this one, trying to feel healthier. What are some of the goals? Maybe you haven't gotten to the doctor's appointment that you needed to get yourself to. Taking that 30 minutes of quiet time to yourself. Or even the walk that you need to have to maintain your own health. I think if we break it up into smaller components of the goal, it's something that's manageable. Put a lot of pictures up here because I wanted to stimulate my thought and maybe your thought as to some caregiving stories that you have lived with. You know, I have one client who has 7 children. The caregiving role falls predominantly to that person who's here in the community, but there are 6 other children who want to be part of their parents' lives, want to be part of that loved one's care, if you will. Now, do they all get along with the same idea about how that should look? Absolutely not. Is there a lot of conversation about what we should do? Absolutely. And you know, as my role as a care manager, I found that I'm able to sometimes bring in a perspective and a mediation, if you will, between families. We've had Zoom calls with 7 children, all different parts of the world, actually, and they all have a chance to weigh in on what they think. And often, it's also a chance for the primary caregiver to say exactly what she needs. What would be the most help to me? I find that if we as family caregivers can give off portions of the care to those who really not only are skilled in that area, so I've got one of the sons, one of the brothers is doing all the financials. He's a CPA in Seattle. It's a great role for him to do. Sometimes it's because that caregiver writes notes. I don't know about you, how many love to get mail? I love to get mail, and I know my mom did. So I have one of those daughters writing the notes during the week. I think that it's very, very important to make it doable, and so I think if we are able to break it up, and also, as I found with this family, to have everyone have a role, they felt invested in the caregiving. Another family that's represented up on this slide, the daughter lived in Dallas, and her parents lived here. She, I don't know, it was before COVID, probably made at least 10 to 12 trips, airplane trips back and forth to see her parents. It's a very challenging role. Some of you caregivers here, I know, who've stopped by our table, are actually doing a wonderful job, but you want to do more. And you may not even have your loved one here that you're caring for. What I was able to do with her is constant communication. I was able to assist by visiting her parents regularly, giving them feedback on what they were doing. And I think if you can connect with individuals that are able to help you and give good feedback on caregiving, it's very, very helpful. Finally, on this one, I have learned that through care management, when we do what I call a home assessment, we come in and we ask the caregiver, and I turn right to them, how are you doing? Because, you know, I often am entering in the home to find out about from the loved one what their needs are as a Parkinson patient. But I think what I need to do, and I often do, is ask the caregiver, how are you doing? So when my blood pressure cuff comes out and I check everybody's blood pressure and I see the caregiver's blood pressure is rising, I'm going to ask them how are they doing with their health management, and I'm going to make suggestions. So I really do believe that my professional caregiving stories have helped me to realize the exorbitant role that you all have. And I think right now what I would like to do is have every caregiver in the audience who's able to just stand up. Would you just stand for a moment? Can you stand? And I think a round of applause. Definitely an undervalued role, but one that is just enormous for all of us to be here. And those of us that came with Parkinson's, I know you're so grateful. I like to have small nuggets, and I don't know about you, but if I read something on my dashboard or on my mirror every day, it sticks with me. One of those nuggets that's up on the slide is that you're a caregiver and not a cure giver. Wouldn't we all like to just wave a wand and cure the world of Parkinson's? But I think what we need to realize, the caregiving role is not there to cure them, but to support them through it. And Nancy Reagan, if you'll see there on the slide, one thing that she did say, and of course it wasn't Parkinson's that she was dealing with President Reagan, but Alzheimer's, but I think it fits, that her recommendation was one day at a time, one step at a time, but love, more love. And I think the more you can have it in your bucket to give that love, the more your loved one's going to feel it. And lastly, I want you to go away realizing that even Beethoven, if you read his story, he was losing his hearing when the Third Symphony was written. Now, if an amazing conductor and person can write a symphony when he's not hearing, it gives me great encouragement that I can do the job that I need to do every day. And I'm here actually to try to encourage you as caregivers and to thank you so much for your support of your loved one. Thank you so much.
Wasn't that wonderful? Let's do another good round of applause for Becky. Thank you for all that great advice. I was taking notes. I don't even have a Parkinson's in our family, but it just seems like some just good advice for all different things. So thanks again to all of you caregivers who are here today and who are joining us virtually. So a reminder that on page 12, 13, 14 is the bios of our wonderful speakers. So if you need to reach out to Becky, for instance, you can do so directly, as if you want follow-ups on those. And our next presenters as well, Julie Lombardi and Liz Horton, they're going to be joining us right now for another movement break. But for instance, they have wonderful, successful businesses that can help you as well. Julie's with the Upstate Physical Therapy, and Liz just opened her own practice, Engage PT/OT Speech. So, you know, the people are here today, and they are a wonderful wealth of information for all of you. So please utilize that. And with that note, let's get back to movement. It's a big theme around here is to get up and move. So please welcome Julie and Liz back to the stage. I think I have to hold the microphone again. Is that my job? Yeah. Yeah.
Oh, there we go. Okay. My eyes are starting to go. I'm at that age where that starts to happen. So I couldn't tell if it was on or not. So earlier we did some movements based on LSVT big therapy, which both Liz and I are certified in. Now we're going to be doing some movements based on something called power moves. And again, Liz and I both have certifications in this and use this in our practice with patients with Parkinson's. Some of it looks very similar because one of the people that created LSVT also created the power moves. So they're similar in that they both focus on the size and speed of your movement. So we'll start sitting. So it's very similar to earlier. So you can go ahead and stomp your feet, kind of wake up your body. Hands here. And we're gonna go, we're gonna lean forward and go forward. And then power up. And let's go ahead and do that with me. Ready? Forward. Power up. Let's do some of that breathing. Breathe in. Say power up with me. Power up. Good. Breathe in. Power up. Breathe in. Power up. Good. Breathe in. Power up. One more. Breathe in. Power up. Good. And so you'll see that works on that posture, trying to get your trunk more upright. Now we're going to do some rocking. So we're going to go. Get ready and rock. Get ready. And you're going to go up. I'll go to the same side for Susan's sake. Get ready and rock. Get ready and rock. Good. Get ready. Rock. Now stay there. Let's go one finger, next finger, next finger. Now let's count with that. 1, 2. Use your loud voices. 4. 1, 2, 3, 4. Good. Let's do that again. Get ready and rock. Stay there. Now flip your hand over and the other direction and flip and the other direction. Good. Just waking up your body. Now we're going to do some twists to help with that rigidity in your spine. So we're going to go both arms out. Actually, let's start with our hips. We're going to drop one knee in and out. Other knee in and out. Next knee in and out. And you can even say it with me. In and out. Or breathe. Breathe in. Breathe out. Breathe in. Good. Now you're going to add your arms to that. So bring your knee in, twist, clap, and open. I'll keep going to that side for you. And clap, and open. Make a loud sound. Clap. Good. Open. See how that made you move bigger? Clap. We're tricky like that. And open, and clap, and open, and clap. And open. Now we're going to do little steps sitting here. So we're going to get ready. Push some weight into your legs. Ready? Get ready and step. Get ready and step. Now really stomp your foot. Did you notice you moved bigger? That's one of those little tricks again. Get ready and step. Get ready and step. Good. And that whole time, if you're talking with me, you're working on your breathing ability as well, right? And that louder voice, that voices can get quieter with this. So let's stand up if you can, or you can keep doing things seated. Hold a chair if you need to for balance. We're going to repeat some of these in standing. A lot of these exercises we do sitting or on the floor, maybe on your belly, on your back, on hands and knees, standing, walking. We can change kind of the surface area of your body in contact with the floor and the position that you're doing it in for different reasons. So we're going to start again with the power up. Ready? Get ready. Squat down low. Power up. Say it with me. Get ready. Power up. Good. Get ready. Power up. Get ready. Power up. Get ready. Power up. One more. Get ready. Power up. Good. Now we're going to do our reaching. Get ready and reach. Get ready and reach. Get ready and reach. Get ready. And now you guys switch sides. Get ready and reach. Get ready. Reach. Get ready and reach. Get ready and reach. Now I'm going to challenge your thinking. I'm going to say right. Let's do it this way first. I'm going to say right, you go right. I say left, you go left. But don't pay attention to how I'm doing it, because I'm going to keep doing it one way. Ready? Get ready, go right. Get ready, go right. Get ready, go right. Get ready, go left. Get ready, go left. Get ready, right. Now, when I say right, I mean left. When I say left, I mean right. Ready? Get ready, go left. Did you go right? Get ready, go right. Good. So that's that. When Liz and I were talking earlier, we were talking about how you get that hesitancy. It's like this, your brain going, go, no, don't go, no, don't go. So that's the types of challenges we throw in with our therapy. All right, we're going to do some twisting. Arms out wide. I'll twist towards you. Okay. No, I'll twist away from you so I don't hit you with my hands. All right, get ready and twist. Get ready and twist. Clap louder. Good. Get ready and twist. Now stretch your arms out wider. Try to reach the person next to you. Get ready and twist. Get ready and twist. Get ready and twist. Get ready and twist. Now we're going to do a couple of steps. Okay? Know your own balance right now and use a chair if you need it. You're going to go get ready and step forward. Get ready and step. Get ready and step. Now go side. Get ready and step. Get ready and step. Get ready and step. Now the back can be tricky. Get ready and step. Get ready and step. Get ready. Now I'm going to trick you again. I'm going to tell you, I'm going to call out, let's say, 2 at a time, and you have to remember. Okay, so first we're going to go forward, back. Ready? Get ready, forward. Now what? Go back. Get ready. Let's go forward and then side. Forward and side. Good. Now I'm going to give you 3. You're going to go front, side, back. Get ready. Front. Good. Get ready and back. Nice job. Good. So those are all the fun things you can do with us in therapy. Okay. I think we're good. Yeah, about 1:13. Okay.
Wonderful. Okay, good job, everybody. Woohoo! Big cheers for Julie and Liz. Thanks so much. Okay, I don't know, my shoulders hurts from like holding this, so apparently I had to work on that. Alrighty, so that's all about exercise. Next, our guest is going to talk about food and medicine. If you can turn to page 64 in your education guide, you can follow along. From exercise to eating we go, using food as medicine. I'd like to introduce you to, it's Chea, right? We met at lunch briefly. So Chea Lee Charles, she's a registered dietitian nutritionist with over 10 years of experience working with the aging population right here in Central New York. Earned her bachelor's and master's in nutrition science at Syracuse. Chea is a board-certified specialist in gerontological, is that right? I didn't practice that first. Nutrition with, in her own words, a passion for using food as medicine. Currently, she is assistant teaching professor in the nutrition program in Falk College at Syracuse University, where I believe you taught this morning already, right? So it's a busy day. Please help me welcome to the podium Chea Lee Charles. Thank you so much for being here today.
All right, good afternoon. So yes, I am Chea Charles. I'm a dietitian. So I'm a gerontological nutritionist, which means essentially that I've specialized in nutrition and aging and all of the nutritional issues that come about with aging, including Parkinson's disease. I've worked with Patrick and Empower Parkinson's for a couple years, but prior to that, we actually worked at St. Camillus together. And we did a program on brain health, and so this has really been a passion of mine and something that I've been interested in for over a decade. So today we're going to talk about using food as medicine, which in the US is somewhat of kind of a novel concept, but in other parts of the world this is not new at all. This has been being done for thousands of years, where they've used different spices and herbs and foods as a portion of their treatment for certain diseases. And so it's something that's come to the forefront of medicine in this country as we try to focus a bit more on prevention and using natural treatments over just waiting until something happens and then treating it with medication and pharmaceuticals, right? Okay, so objectives for today. I'm going to talk about the evolution of nutrition concerns that I have seen commonly and people have expressed to me over the course of Parkinson's disease. Certainly not everything that I talk about is going to apply to everybody, but chances are it'll apply to somebody. And so I've seen a wide range of things, and we'll talk about all of those today. We're also going to talk about nutritional goals and priorities for people with Parkinson's disease. So throughout my career, I also did home care for a long time, and what I see happen is that this doctor tells you you can't have salt, and then this doctor tells you you shouldn't eat fat, and then this doctor tells you you need to eat more of this thing. And then slowly but surely, with all your different specialists, you've whittled down to you essentially can eat cardboard and water. And so then people come to me and they say, I have no idea what I can eat. So one of my goals always is, when I sit with someone, is to what I call nutritionally prioritize. And what that is looking at you as a whole person, not just all these different diseases on a piece of paper, and say, okay, what can we do nutritionally that is going to benefit you the most, make you feel the best, make you have the best outcomes? So that's what I mean when I say nutritionally prioritize. We're then going to talk about ways to promote ideal digestive function. Constipation and other digestive issues are very common in people with Parkinson's and something that I've worked with a lot. So we'll talk specifically about that and how to help manage that. And then the presenter before me obviously did a fantastic job talking about resources for caregivers and gave you some good avenues. I will talk about a few resources that are specific to nutrition for caregivers and kind of mimic a few of the things that she was saying. So what is nutrition? One of, I would say, the biggest misconceptions is that as a dietitian, I'm going to put everyone on a diet. So I will go in a place and people think I'm the food police, and then I'm going to tell them they can never have another piece of cake again, and that's my only job. And so my job is not that. I am a dietitian that believes you can eat cake and you can eat anything that you want. We just have to figure out how to make it all fit in. And so we can use food in a way that makes us happy as well as makes us healthy. And that does not include going on a diet, right? I don't know too many people who are ever on a diet that were very happy. So that's not my goal. I'm never going to put you on a diet. So nutrition, what it really is if you look in a textbook, it is the biochemical and physiological process by which organisms use food. So essentially, it's how we eat and what we eat that makes us healthy and makes us continue to live. It is not about too much carbs and too much fat and too little protein and this and that and the other thing. It's not about that. It's eating healthfully to promote extended life and best quality of life. So nutrition is important throughout the lifespan, and I think what happens is that, at least I've seen in my career, that in infants and toddlers and children, we tend to focus a lot on nutrition because we think, oh, they're children and they're growing, and we need to make sure that we're feeding them the right things so that they grow and they're healthy and they're strong. And then as people age, they tend to kind of put the focus on nutrition a bit on the back burner. And so today, my hope when you walk away from here is that you bring it all the way to the front of the stove, because nutrition plays a role in every single process and organ system in your body, every single one. So what you eat has an impact on everything from how you move, to how healthy you are, to how you sleep, to how you heal, to your mood, to your cognitive function, to your muscle ability. It literally plays a role in every single thing. So we need to make sure that we're prioritizing it all through life. Your weight status is also important. Now, does that mean that I think everyone should go and make sure that they are not overweight and that they are as thin as they can be and that they meet that healthy, normal idea on a BMI chart? I absolutely do not think that. Over the age of 65, research is very clear and shows that weight loss does not promote improved health or extended life. So what happens when people over the age of 65 lose significant weight is they actually tend to become less healthy. They're at a higher risk of falls, a higher risk of hospitalizations, and a higher risk of complications that in some cases can lead to death. So I do not want any of you to go home and lose weight. I actually want most of you to maintain your weight. And so that's also a surprising thing, I think, when I sit down with people and they say, oh, well, I'm about 20 pounds too heavy. And I say, okay, that's fine. Because it is fine, honestly, especially in Parkinson's, when we're talking about a disease that tends to deteriorate your muscle mass. The last thing we want to be doing is promoting that to happen further. And if you're losing weight, that actually can be promoting that. Adequate nutrition is also important in terms of cognitive and neurological function. So the way that your brain functions is highly related to your nutritional intake. One of the biggest trends that has become the bane of my existence over the past decade or so is the low-carb diet trend. Your brain has to have carbohydrates to function properly. And if we don't give it carbohydrates to function properly, it actually has to pull energy from the rest of our body by breaking down other tissues, which is, I don't think, what we want to have happen, right? So it's important for cognitive and function to make sure that we are eating enough of every nutrient and that we're not eliminating anything specifically. So nutrition specifically related to Parkinson's is a newer area of research, and there are some interesting studies going on as we speak. To date, as of today, there is no one specific type of meal plan or quote-unquote diet specifically prescribed to people with Parkinson's disease. But there are things that I'll talk about as we go through in the upcoming slides that we do know help in terms of prevention, and so prevention in worsening potentially of Parkinson's and in treatment. One of the big things that we know has huge neurological and cognitive benefits is adequate vitamin B intake. So vitamin B is involved in cell metabolism, so essentially the life cycle of your cells. B6, B12, and folate are common deficiencies as people age, and those have a direct correlation to decreased cognitive function. If someone is actually B12 deficient, the symptoms can mimic dementia. I have had patients who actually had families who thought that they were developing dementia, and they went to their primary care, and I said, ask them for a B12 level, ask them to check your B12, and they were B12 deficient, and their cognitive function had declined because of a vitamin deficiency. They did not have dementia. So that's how important some of these things are. Folate deficiency, also super common, which can lead to anemia, which can lead to an increased risk of falls because increased energy, increased tiredness. Our vitamin B12 levels naturally decrease as we age, and it's because as we age, we make less and less of a certain enzyme that helps us to absorb vitamin B12. So as we age, we absorb less of it. So that's why B12 becomes a common deficiency as we age. Usually, if you are deficient, you have to get it, taking a pill supplement isn't going to help you. That's something I like to point out. You would need it like through an injection, like a shot. So food sources of vitamin B12 are those that you see listed here, which I will not read all through for you. B12 is an important one also for any of you that eat highly plant-based diets. So if you don't eat a lot of meat and you don't eat a lot of dairy, there's also a chance that you're not getting enough B12 in your diet regularly. Folate is common in fruits and vegetables, as well as our grain supply is fortified with folate. One thing also that has become very trendy lately is the gluten-free phase. Some of you may have physicians that have recommended that you go gluten-free. There's very limited research showing any benefits of avoiding gluten if you are not somebody who has celiac disease. And what can potentially happen if you are avoiding gluten is that gluten-free products are not fortified with extra folate. Our regular wheat supply, grain supply in the US is fortified, and that is where a large amount of people actually get the majority of their folate intake in a day. If you are switching to a gluten-free diet, chances are you are not getting that fortification. And so it's something to talk about with your doctor or with your dietitian if you really need to be following that diet. Another thing that is important dietary-wise is antioxidants. So I'm sure you've all heard about antioxidants being healthy for you. But how many people here could honestly tell me what a definition is? Like, what does an antioxidant do? Show of hands, right? So everyone knows that they're good for you, but no one really knows why. So, and that's because nobody ever really tells you why. So here I am, I'm here to tell you why. So antioxidants function in our body like an army. So we are bombarded all day, every day with toxins that essentially attack our cells, right? So everything from the shampoo that we use, to makeup, to the air that we breathe, to things that are in our water, to the food that we eat and the pesticide residues on it, and all of these things. These are toxins, essentially. Our body is able to fight them off and filter them through for the most part. However, we are constantly being bombarded, our cells are, with those toxins. Antioxidants help in that they create kind of an army, like a wall around your cells, and help prevent those toxins from damaging the cells. So that's why antioxidants are important, because they are essentially helping cells to stay healthy. If you are helping the cells in your body to stay healthy, there's a much less likely chance that you will develop certain diseases or have certain diseases worsen. So that's why antioxidants are important. There's a few different ones that you hear about mostly. Carotenoids are one. That's essentially, it's a form of vitamin A. So that is why you hear like carrots are good for your eyesight and such things. That's carotenoids that are doing that. And that is actually the pigment that turns certain vegetables orange. So when we say things like eat the rainbow, antioxidants are really the reason that we're recommending that, because all of the colors that make fresh fruits and vegetables, those specific dark colors, are antioxidant. They have antioxidant properties. Flavonoids are another compound that are found in plant-based foods. So eat enough fruits and vegetables. There's lots of reasons that we promote that, but antioxidant function is one of them. Also, there's lots of herbs that have flavonoids in them. So using fresh herbs over dried herbs in your cooking is helpful. And vitamin E is also very important for cell health. Vitamin E is found in different vegetable oils, like safflower oil and corn oil, whole grain products, peanut butter. Those are very good and healthy for you. Vitamin E is probably the most researched antioxidant, so we do know pretty much without a doubt that that is helpful in cell health. Another thing that I promote to people is enough omega-3 fatty acids. So omega-3 fatty acids are considered an essential fatty acid. That means that we have to get them from our diet. Our body cannot make them on their own or convert certain fats into these. You have to get them from your diet. So if you're not eating enough of these foods listed up here that are high in omega-3s, then chances are you're not getting enough DHA to really have that protective benefit that we know omega-3 fats can have. Studies have shown a positive association between cell health, cardiovascular disease, neurological health, with good intake of omega-3. However, all those studies show show a good amount of help from food sources, not necessarily from a supplement. So in my food as medicine push that I'm always giving people, it's because I would rather have you get all of these things from actual real food and not from a bottle, not from a shake, not from a pill, not from any of those things. We do not digest, absorb, utilize those nutrients the same when we get them in supplement form as we do when they're in a food with other things. So when you hear about omega-3 fats being healthy, it's from food sources. Now, if you are someone who already takes an omega-3 supplement or your doctor told you to, it's not hurting you by any means, but we do know that if you're getting it from food, it's probably more beneficial than the pill that you're taking. Other dietary fats, so these are ones that we don't want a lot of. These are ones that have been shown to be harmful. Saturated fat and trans fat. Trans fat is the fat that comes from processing of fats. So a lot of cookies and baked items and potato chips and things like that potentially have trans fats in them. These fats are harmful in excess because they actually increase inflammation in your body. And having chronic inflammation in your body creates a state of higher risk for other health issues, as well as a potential worsening of Parkinson's symptoms. It also is associated with cardiovascular disease, and trans fats, for the most part, there was actually legislation pushed through that manufacturers were supposed to eliminate them as much as possible. But if you look at an ingredients label and you see partially hydrogenated vegetable oil, that product contains trans fats. It might be a small amount, but if that is in the ingredients list, that means that there's trans fats in that product, because that hydrogenation process is what creates trans fats. So although there's not a specific diet that we recommend for Parkinson's, there are certain styles of eating that we know are potentially helpful. And one of them is the Mediterranean diet. The Mediterranean diet is a diet that's very high in fruits and vegetables, so high in those antioxidants that I just talked about. It's high in fish, so high in omega-3s. It's high in legumes, so it's high in the healthy fats that we talked about. It's high in grains, meaning that it has good vitamin B intake and good fiber intake. So there's lots of different versions of the Mediterranean diet. If you were to Google it, there's a million different versions of what the right one is. But essentially, it is the diet that traditionally was eaten in the Mediterranean area. And these people in this area historically have improved health outcomes with certain diseases, including Parkinson's disease. There's actually, have any of you ever heard of the blue zones? Right, so the blue zones are these areas where there's a disproportionately high number of people who live to be over 100. When you look at the diet of these people, many of them are following a Mediterranean-style diet. So nutrition research is hard because how do I tell that somebody didn't get cancer or someone didn't get Parkinson's because they ate a lot of blueberries, right? Because nobody just eats blueberries. We all eat tons of different things all the time. So nutrition research is difficult because there's so many components that go into what we eat all day, every day, that it's very hard to say this one thing. If you eat enough of this one thing, then it means you won't get a certain disease. We can't necessarily say that, but what we can say is these people who eat these types of foods tend to have lower rates of certain diseases. The MIND diet is the current diet that's being mostly researched in terms of Parkinson's and other cognitive neurological diseases. The MIND diet is kind of a version of the Mediterranean diet, focused on plant-based foods. It limits the intake of animal products even more so than the traditional Mediterranean diet does. It also eliminates, well, doesn't eliminate, but minimizes the intake of saturated fat. And in the preliminary studies that have come out, people who follow this diet have had improvement in symptoms of Parkinson's because this diet tends to decrease overall inflammation in the body. So common nutritional concerns of people that I've worked with over my time in working with Parkinson's disease. One is inadequate protein intake, and I'm going to go into all of these in a little bit of detail. So inadequate protein intake. I worry when I see someone who doesn't necessarily eat meat anymore. And so I immediately think, okay, how are they maybe getting enough protein? As we age, people tend to decrease their protein intake for lots of different reasons. Maybe you've become lactose intolerant, so you don't eat dairy anymore. Maybe you have chewing or swallowing difficulty, so meat has become difficult for you. Maybe you have diverticulosis, so you don't eat nuts anymore. Maybe you have high cholesterol, and so your doctor told you to not eat too many eggs. Well, there's pretty much all your sources of protein right there. So if we're eliminating or lessening all of those, chances become that we start not eating enough protein. At the same time, as we age, we don't absorb protein as well, and so the amount you have to eat actually increases. So sometimes I see people and their protein intake has decreased, but their needs for protein have actually increased. So we chat about that and figure out ways specifically that we can meet our protein needs with their specific issues. Now I know a lot of you are on certain medications where we have to worry about protein intake and the amount of timing that needs to be before and after medications. That's something that I work with people individually, but there almost always is a way to meet your protein needs even with the timing. Some people, if they're on like a 4-time-a-day medication, we might have to do some kind of supplement drink, protein shake, thing like that, but most of the time we can meet it. Protein is so important in Parkinson's because adequate protein intake preserves your muscle function. If you are not consuming adequate protein, your body will break down muscle tissue for other uses in the body. The last thing anyone in this room needs, whether you have Parkinson's or do not have Parkinson's, is to have muscle tissue being broken down because you're not eating enough protein. So especially if you're someone who has a disease that already your body's trying to do that, we don't want to exacerbate that and make that worse. So we want to make sure that you're getting enough protein so that your muscles are as strong as possible so that we're decreasing that risk of falls. The source of protein is important, so whether it's an animal protein or a plant protein, that does make a difference, and I would chat with somebody individually about what way we should go about. Another issue that we run into is unplanned weight loss. Unplanned weight loss, as I said in the beginning of this speech, is problematic because it shows very strong correlation to hospitalization and death. We do not want people losing weight, especially if they are not intending to. If all of a sudden I see somebody and they say, I've lost 10 pounds in the past couple months, I see a huge red flag go up and say, okay, we need to chat because something is going on, we need to fix that, we need to stop it. And even if we can't regain the 10 pounds, we need to not have one more pound go off. And so let's figure out what's happening, and let's figure out how we need to adjust your meal plan so that you don't keep losing weight, which really isn't usually that big of changes that people think. Sometimes people have decreased appetite and they think, oh God, I couldn't possibly eat another thing in a day. I have to force myself to eat as it is. There's lots of ways that we can increase the calorie content of foods without you having to actually eat more foods. There's lots of ways that we can do that. If you do lose weight, you tend to have higher risk of falls because you also tend to have muscle wasting. But the other thing is, especially in these COVID times, unplanned weight loss leads to decreased immunity, because if your protein intake is low, our immune cells are made of protein. And so that means that your immune function can't be as high as it could be if you have unplanned weight loss and protein wasting. Dehydration is a big one, and this kind of leads us into the digestive issues. So dehydration is extremely common. If I were to take the blood work of everybody in this room quickly, it would probably tell me that about 55% of us are borderline dehydrated. There's a large percentage of the population that walks around kind of just on the brink of being dehydrated all the time. It doesn't mean you can't function. It doesn't mean that you necessarily feel bad, but you're like just hydrated enough to be able to function. A lot of people are not meeting their fluid needs. This especially comes into play if people are starting to have swallowing difficulties and need thickened liquids. Fluid intake tends to decrease. Our sense of thirst actually also decreases as we age, so you may just not feel as thirsty as the years go along, even though your fluid needs actually stay the same. And so we worry about dehydration for lots of reasons. One, because it can make you very sick very fast. So there's very serious health complications. If you aren't drinking enough, like significantly, say you're sick and not really drinking, that will land you in the hospital within a few days, right? Water is the best option. However, put a little asterisk next to this part. Everything you drink does not have to be water, okay? A lot of people don't love water, myself included. I'm a dietitian, and I will freely tell you, unless I'm working out, I cannot stand to drink a glass of water. It's just, I hate it. So I have figured out other ways that I put lemon in it, or I buy like sparkling water, which by the way is not the same as soda. Sparkling water is just carbonated regular water. You can drink that the same. So we would figure out, like, what do you like to drink? As long as it's decaffeinated and non-alcoholic, it is contributing towards your hydration. Okay, so decaffeinated and non-alcoholic. So juice counts, milk counts, soup that you have for lunch counts, decaffeinated coffee and tea count. Ice cream actually counts a little bit. So when we talk about your fluid needs, it's all these things in a whole day added up that is actually making you well hydrated, okay? I think sometimes people get overwhelmed when they think, how could I possibly drink 8 more glasses of water? I already drink coffee and this and this. There's no way that I could drink 8 more glasses of water. It doesn't have to be 8 more glasses of water, right? You want to drink water mostly, but we can certainly add in other things, and that still counts towards your hydration. Swallowing difficulty, I'm sure there's some people in the room who have experienced this or have loved ones who've experienced this. If you haven't, that's great. But some people do, and it leads to a need for ground food or pureed food or thickened liquids. So choking becomes a concern at this point. People tend to eat less if the act of eating becomes more labor intensive, right? If you have to sit down and it takes you 45 minutes to eat half a plate of food, then you probably don't want the other half of food. I understand that, because who wants to have every meal become an hour and a half long process? So for you caregivers, that's something that we do have to think about, right? If sitting there for a meal is kind of like a job, people aren't going to want to do it all the time, right? They're going to not want to sit there for that long. So in that situation, we also have to look at all right, if we're only going to eat this much, how do we make that the most high calorie, jam-packed, full of nutrition, little bit of food that we possibly can? So we look at that in people who have swallowing difficulties as well. I would work with a speech therapist, and we would work to figure out what's the least restrictive way that we can keep somebody safe and still meet their nutrition needs. And then constipation. So constipation is a very frequent issue that I come across. One is medication related. Some of your medications actually cause constipation. The other reason is that in Parkinson's, the muscle movements in your digestive system actually slow because of the disease. And so food literally is not being pushed through your digestive system as efficiently as it usually is. So although there may not be something we can necessarily do about the muscle issue itself, how we eat can impact the movement of food as well. So one, and the biggest thing, also highlight this, most of the time when I see people who are constipated, it is less of an issue with what they're eating than it is how much they're drinking. Most people, when I see them and they're constipated, are also slightly dehydrated. If you are not drinking enough fluid, it doesn't matter how healthy you're eating as far as the foods go, the water is not getting in to push everything through your digestive system. So the first thing that we tackle in constipation is making sure that you're well hydrated. Then we would go on to thinking about other types of fiber and making sure that you have fiber intake that's adequate. But we do not increase somebody's fiber unless they're drinking enough. Because you know what happens then? We create a giant, backup, and it makes the whole issue way worse. So we're not increasing fiber before we're making sure that your fluids are adequate, okay? The other thing that can help in terms of preventing constipation issues is making sure that you're eating enough foods that have the probiotics and prebiotics in them. We've all heard about those, right? Probiotics are essentially the healthy bacteria that's in some foods, especially fermented foods, so things like yogurt and those types of things. So we do promote yogurt. You'll hear me promote yogurt to people all the time. It doesn't really matter what kind. It doesn't have to be the Jamie Lee Curtis Activia kind because she says so on TV. All yogurt has probiotics, okay? And it's those probiotics that help make a good digestive environment in your stomach that helps break things down efficiently and move them through your system. So having a good GI health is one of the most important things in preventing constipation as well. So overall, when I work with anyone, but especially with Parkinson's patients, I am looking at how for each person we're optimizing your digestive function and absorption. And this is where I'm nutritionally prioritizing. If you have swallowing difficulties, certainly we're worried about you choking, we're gonna deal with those first. But overall, how can I make sure that you're getting enough nutrients, that you're absorbing them properly, and that we are moving everything through your system in an efficient manner? That's what I am gonna do when I sit down with somebody or when I conduct my classes. This is my son. So for those of you who attend Empower Parkinson's in the gym, I, this fall, am going to start doing, and I've done them in the past, and I know some people in this room that I see. So we're adding in a nutrition series twice a month, and we are going to do some classes where we have a topic every month, and we're going to talk about how to meet a certain nutrition need. And then the second one, we're going to do a cooking class, and I'm going to Rachel Ray, and we're going to cook something that deals with the topic from earlier in the month. So that's a series that's going to be starting actually this month. So kind of a shameless plug for you all to tune into that because they will be Zoomed as well as in person. But I have the picture of my son up there because I also, in addition to being a dietitian, I own a farm. And so one of the things that is really a big passion of mine is growing things that are healthy for my family and that are healthy for us to eat and doesn't have tons of pesticides on them. There's not conclusive research, 100% that says that Parkinson's is caused by pesticides, but there's pretty strong research showing that it certainly doesn't help. And so the more we can get fresh, whole, clean, natural food into your diet, the more healthy you're gonna be, the better you're gonna feel, and likely the better your Parkinson's symptoms are gonna be. So we have some exciting plans maybe in the works for the spring, but so stay tuned to that. But I like to bring that into my work. And then resources for caregivers, we already had the great presentation. There's a few different websites that you can visit for nutrition-specific information. Parkinsons.org actually has a decent nutrition section that talks about some of the things I talked about today. Also, the Academy of Nutrition and Dietetics. That is my professional association that I'm a part of, that all registered dietitians in the US are a part of. They will provide information on there as well as links to lots of other resources. Anything that is on that website has been proven by research. It's a scientific study that's done, so you can trust any of the information that's there, and you can trust any of the links that take you from there. One of the frustrating things with nutrition is that there's so much information out there. Sometimes it's hard to weed through the stuff that's not true to get to the stuff that is true. If you start at that site, then you're going to be on the train to only getting good quality information. Or you can always call me or contact Pat, who can get in touch with me, and I can always lead you in a certain way as well. Okay, thank you very much.
Wonderful information. Thanks so much to Chea Charles. Another round of applause. Thank you. Really good information. And finally, we are into our last segment. It's been a wonderful day, spending it all here with you. As you navigate this journey with Parkinson's disease, we want to give you an update on the organization that's been a key resource for Parkinson's patients all across Central New York, and that is Empower Parkinson, Inc. Details on page 75 if you're following along. Let me tell you about Marlene Reinman before she comes up to the podium. For the past 9 years, she's volunteered with the Parkinson Education and Support Program of CNY. She's chaired this conference for the past 9 years. Yay, Marlene, appreciate it. And she graduated from SUNY Cortland, has spent 20-plus year career working with seniors in the CNY community. Quite a treasure. We're happy to have her managing all of us. And please help me welcome Marlene Reinman to the stage.
Good afternoon. I got to get used to working this. This is not my thing here, so. Oop, it didn't go anywhere. There we go. Okay. I'm sorry that Pat is unable to be here today to share with you his passion for Empower Parkinson. I will do my best to introduce you all to this amazing organization that I have fallen completely in love with over the last year and a half. Empower Parkinson supports people with Parkinson's disease and their care partners by offering comprehensive programs and services that improve one's quality of life. We are a place to turn, a community, and a hub of evidence-based interventions that provide education, support, and physical exercise. Did it go? Did it go to the next one? Okay, thanks, sorry. We originally formed as Rock Steady Boxing in February of 2017 in the outpatient department of St. Camillus. This is the actual picture of their very first meeting with 10 participants and volunteers, some of whom are here with us today as speakers and in the audience. In 2018, they lost their home at St. Camillus due to the closure of the outpatient department, and they moved to Tipperary Hill. Pat shared this story with me when I was preparing to cover for him today. The day that Pat found out that he had to move from St. Camillus, which happened to be just 3 days before Christmas, he and Julie Lombardi visited the DC boxing gym on Tipperary Hill. Their first thought when they entered the gym was, oh goodness, our boxers are never going to want to box here. It was a dark, smelly old warehouse. But with very limited options, he went ahead and sublet the space. The first boxers that came through the door said, "This is great. Look at the boxing ring. This place is so cool." They were so grateful to have a home for their program. And this is where Rock Steady Boxing became Rock Steady Boxing of Syracuse. Oh, I gotta go ahead one. Go back. Sorry. Okay. Okay. Then, in 2019, DC Boxing had to relocate. Thus, Rocksteady Boxing of Syracuse was to become an orphan once again. Never deterred, Pat and his volunteers began looking for a new home. DC Boxing, having seen firsthand the value of Pat's program and personally dedicated to this program's survival, stepped up and offered the opportunity for the boxers to follow him to where is now their current home, the Pacific Health Club of Liverpool. This is where we became Empower Parkinson Incorporated, a 501c3 not-for-profit organization. Okay. After a grant from the Parkinson's Foundation, we were able to increase our program offerings and visibility. Today, despite being in the middle of a pandemic, we have over 150 people with Parkinson's active in Empower Parkinson's programs. We have a nutritionist, who you just met, a psychologist, a speech therapist, and several physical therapists, who you've also met, who provide regular programs to our participants. Our programs include, but are not limited to, the Rocksteady Boxing with over 100 active boxers, yoga, tai chi, dance, chorus, pedaling for Parkinson's, the Big and Loud programs, polling in the park. We have 5 different targeted support groups, nutrition programming, educational programming, and now this conference. These programs offer camaraderie, support, and result in considerable improvement in the physical function and overall quality of persons with Parkinson's and their care partners. I'd like to share with you a short story about the merger of Empower Parkinson's and the Parkinson's Education Program of Central New York. This conference began 9 years ago through the effort of Cynthia Stevenson and myself, along with support from several of the exhibitors that you met earlier today. The success of that first conference led to the formation of the Parkinson's Education and Support Program. Soon after that, Roseanne Suskin and Marty Pond joined Cynthia and I. Each year, our conference has grown in size, and eventually we outgrew the ability to manage this conference that usually has over 350 participants and more than 40 exhibitors on our own. It was at this point that we were introduced to Patrick Van Beveren of Empower Parkinson. Cynthia and I requested a meeting with Pat in hopes of convincing him to take on another program within Empower, our conference. Cynthia and I were very nervous about meeting Pat. We prepared for days. We were going to have to convince him to take on our conference. Our conference had to benefit Empower. What happened in that meeting is a moment that I will never forget. We were sitting across from Pat on folding chairs and a rickety card table in the middle of a stinky gym, and we could hear the boxers in the other room boxing. Cynthia and I started to give Pat our pitch for the conference. Within minutes into our carefully crafted presentation, Pat reached across and tapped his fingers on the table. He studied us carefully and he said, "Exactly what is it the two of you want from me? Because whatever it is, you've got it." Brings tears to my eyes today. That is how we started this amazing merger and a beautiful friendship. Finding and establishing funding sources is exceptionally important for nonprofits. Based on the success of our programming, we have been able to establish a grant history of over $40,000 in the last 2 years. In the summer of 2019, Empower Parkinson team participated in Moving Day and raised over $5,500, the most of any team there. It was a great outpouring of the Central New York Parkinson's community to support Parkinson's research. As you can see from the past several slides, since 2017, we have been able to grow our programming and establish a grant history and enhance the Central New York Parkinson's community. And then the pandemic hit. This is when the Central New York Parkinson's community became Zoom proficient. Empower Parkinson and our team of volunteers were not going to let a little pandemic get in the way of us providing essential programming to our members. We conducted boxing and support group via Zoom. We hosted outdoor Parkinson's awareness days and met in the park for summer picnics. We hosted many Zoom educational webinars. We established a conference website that has to this date hosted over 3,000 visitors from around the world. So, what does the future hold for Empower Parkinson and our members? It has long been a vision of ours to establish a consolidated hub for Parkinson's programming in the Central New York community, a place of hope, a bank of knowledge, and an opportunity for movement, a community of support and friendship. We are looking ahead to design our future, the creation of our own home, to share our expertise, growing our programming, and launch innovative program options, a place to serve and connect the people with Parkinson's, their families, and the professionals that provide services to them. The Board of Directors has determined that it is in our best financial interest to own our own building when we are looking at the long-term financial planning of Empower Parkinson. Okay. What have we been doing? We have been working closely with a I can't say it. Say it? Philanthropic consultant. We have contacted our state and national legislators. We have identified potential grant agencies, and we continue to increase our visibility. What can you do to help, you ask? It is all about making connections and building relationships. People who are most likely to help us have an emotional connection with Parkinson's. If you have knowledge of a funding source, consider sharing our story with them. If you have a particular skill or expertise in fundraising, consider joining our family. This is a really big lift. The board has determined that we need to raise $1.7 million to own our own building. But we know that this vision will come to fruition through the dedication and determination of our Parkinson's Village. Pat has asked me to convey to you today his heartfelt thanks to the annual conference committee, the board of directors, and the coaches, support group leaders, activity leaders, and volunteers. Without these people, Empower could not do what we do today. I would like to leave you with a final thought. Throughout our lives, we all face adversity. Sometimes we may feel like we are stuck in a hole, unsure of how to get ourselves out. During these times, we may have friends that will offer advice, friends that will listen to our complaints without judgment, and friends who will lend a helping hand. But if we are really lucky, we have friends who jump right down in that hole with us, and they say, "Don't worry, I've got you. We will climb out together." I want you all to look around you today. This is what Empower Parkinson was established for. Together, we are better. Together, we will move forward. Together, we will create a space that supports, educates, strengthens, and empowers us all. Thank you so much for being here today.
Wow, thanks, Marlene. Powerful. So, I guess on behalf of Marlene and Pat and Cynthia and Marty and Roseanne and that team of people who started this program 9 years ago, I want to say thank you. Thank all of you who are here in person, who are joined us virtually. Thank you to our speakers, wonderful speakers, and all the exhibitors too. Thank you for taking the time to come together, learn more and share more, and we're so thankful and honored to be here today with you. And that's the end of our conference. Go out and get moving and get healthy. Please, a reminder to put on your mask as you move around the space and exit slowly and patiently, leaving a little elbow room with everybody around you. Thanks so much and have a great afternoon.